Dr. Nitin Das, third speaker is not here. Okay. So we have, actually we can get started if they come. Okay. To the whoever speakers are here, your time is 10 minutes, you know that. Ideally, you finish your talk in 8 minutes time, so there is 2 minutes for discussion. Discussion part is important because it influences the judges probably to give better grades. So, but if you want to talk for 10 minutes, that's fine. But then there's no time for discussion. We are hard pressed for time. Exactly 10 o'clock, we have to start the presidential oration, which is 120 minutes from 8 o'clock. And we have 12 papers, so 10 minutes each. So we have no extra time. Already we are running late.
Good morning. Welcome to day 2. We will be commencing with our free paper session. I welcome our chairpersons, Dr. Harun M. Pillai, Dr. Ajit, and Dr. Ayudurai. I invite our first presenter, Dr. Asin Kabir.
Good morning to all my teachers and my colleagues. Today I am going to present about a surgical outcome of degenerative cervical compressive myelopathy in elderly patient. It's a comparative analysis. Degenerative cervical compressive myelopathy is a slow ongoing degenerative disease of cervical spine caused by progressive narrowing of cervical canal and compression of spinal cord. This is a age-dependent disease, and in fourth decade of in age of around the fourth decade, there is 30% of population which are affected with degenerative compressive cervical myelopathy, and by the sixth decade, it comes about to 90% of population. According to the United Nations analysis, in 2015, 12.6% of population worldwide was aged more than 60 years. And by 2030, it would be 16.5%, and by 2050, it is estimated to be 21.5%. So, the question of surgical treatment of higher aged people suffering from degenerative compressive myelopathy is becoming more and more important. And surgery remains the gold standard of the treatment. The reluctance of surgeons to perform surgery in elderly people is because of the age itself. It's an independent factor for increasing the morbidity and its associated additional comorbid medical conditions. Even though surgical, after this all, there is controversies regarding the surgical outcomes in elderly patients. So this study is about comparing the post-surgical outcome of elderly, that is aged more than 65 and above, and comparing it with the patients which are done below 65 years of age. The aim is to analyze the preoperative function, the postoperative functional outcome in patients undergoing degenerative compressive myelopathy surgery using the modified Japanese Orthopedic Association score and the mean modified Japanese Orthopedic Association score and neurological recovery rate. The study was conducted in my hospital at MES Medical College, Perindalmanna, and the study population was the patients which are presented from Jan 2018 to June 2022 and who has undergone the surgery. And there were two groups. The group 1 was 65 and above years of age, which included 15 cases. And group 2, there were about 56 cases which were below 65 years of. It is actually a retrospective analysis. The inclusion criteria for the patients were all the patients presented with the features of degenerative compressive myelopathy and who has undergone the surgery. According in exclusion criteria, the cervical degenerative disorders other than degenerative compressive myelopathy, congenital abnormalities of cervical spine, rheumatoid arthritis and metastatic diseases, fractures of unknown age, instability of cervical spine, and traumatic spinal cord injury. These cases were excluded. Therefore, after this, we had total of 71 patients who underwent the surgery, both anterior and posterior approach. Among the 71, 51 were above 65 years of age, and 56 were below 65 years of age. The data collected were age, sex, comorbidities, symptom presentation until surgery, preoperative modified Japanese orthopedic score. Then postoperatively also we analyzed the modified Japanese orthopedic score, the mean Japanese orthopedic score, and neurological recovery rate after 6 months postoperatively. Statistical analysis were done by SPSS trial version, and ethical clearance from the institutional and ethical committee were obtained, and informed consent was obtained from all individual participants included in the study. After the analysis, the observation we found is the mean age of people in 65 and above were 66.43 plus or minus 4.67, and below 65 was 44.16 plus or minus 4.28. There were 4 females and 11 males in group 1 and 25 females and 31 males in group 2. In our study, the duration of symptoms till the surgery was undergone was between longer in case of G1, that is the group 1 where elderly people are included. Mostly it may be because these patients will be having the comorbidities. So they think that their condition, daily condition may be deteriorating due to aging. So it may be considered as normal or may not be recognized early. Surgical treatment, we did an anterior approach and posterior approach. In anterior approach, we did 60% went for anterior approach and 69.7% went for posterior approach. Not anterior approach, 40% went for posterior approach in group 1. And in group 2, 69.7% underwent anterior approach and 30.3% underwent in group 2. The assessment was evaluated before and 6 months after the surgery with modified Japanese orthopedic score. And the improvement in the score was also calculated by using the post-operative Japanese orthopedic score minus pre-operative score to analyze the post-operative outcome. The neurological recovery rate was calculated by the formula suggested by Hirabashi and Satomi by giving this for a post-operative Japanese score minus pre-operative score divided by full score, that is 18, minus pre-operative score into 100. And the results came like, these were the symptoms for chiefs presenting symptom of these patients. In that, the group 1 patients, that elderly patients, the chief presenting symptom was ataxia. And in case of a younger patient, so the age below 65, it was cervicobrachial neuralgia. This is the tabular column which are explaining this thing. We will be explaining coming slides. This is the neurological outcome of modified Japanese orthopedic score comparing the pre-op and post-op. In group 1, the pre-op score was around, mean score was around 13, and the post-op score was 15. Comparing with the group 2, that is age below 65, the pre-op score was 15 and the post-op score was 17. And the neurological recovery rate, around 44% recovery was seen in group 1 patients, that is elderly people, and 66.7% of improvement was seen in group 2 patients. The mean postoperative improvement score when calculated was almost similar. It was 2 in case of young patient, that is less than 65 years of age, and it is 1.95 in case of elderly people. So coming to the discussion, the demographic changes of population have led to an increase in age-dependent disease. So understanding the treatment of elderly patient has become more relevant. Only few articles have addressed this topic so far. These are a study by Tetrold has shown that low orthopedic score and longer duration had worse result, and age is also a potential predictor. A study conducted by Nagashima et al. Out of 37 patients which are above 80 years of age and younger population, the outcome was worse than the younger population, but the improvement in JO score was significant, and it increased the lifestyle of the patients positively. In our study also, the neurological recovery rate was lower in elderly compared to the younger. In Machino et al. Study, it divided the patients into 3 groups, and the elderly group showed low recovery rate in Japanese orthopedic score, but mean Japanese orthopedic score improvement showed no difference among these groups. This was similar to our study. Now the Madhavan et al. Study showed that the postoperative and long-term improvement in all patients have been remarkable, and improvements in mobility and independence leading to reduced nursing care being required. It was similar to our study. And the study by Gumbrich et al., it was divided into more than 70 and less than 70, and the orthopedic score did not differ significantly. The improvement in the score was not very different between these 2 groups after the 6-month surgery, and this was also comparable with our study. So the conclusion is preoperative and postoperative MGM score are significantly lower in older patients compared to younger individuals. Mean orthopedic score improvement is similar. With respect to postoperative orthopedic score improvement, older patients still benefit from surgery. Surgery is still useful due to clinical improvement of symptoms and resulting lower need of daily care. Therefore, surgical treatment of DCM is a valuable option for those patients. Limitation of our study was, it was a retrospective analysis, and it was a short duration of follow-up, and there was significantly less number of patients in elderly group, that is 15 cases compared to the other group.
Thank you. Just a few comments about your study. One thing, the younger patients had cervicobrachial neuralgia. The other people had spasticity rather than ataxia. So obviously spasticity recovered not so well as cervicobrachial symptoms. The other thing is not very clear is which patients you did anterior, was it ACDF, was it multi-level corpectomy, who had posterior laminectomy with or without fusion, laminoplasty, all this information is lacking. But yes, I think, anything else?
It's a good study. You talked about the modified Japanese JAS score. What's the difference between the original and the modified?
The total score in original Japanese orthopedic score was 17. In case of modified, it was total score was 18. And in modified, it was divided into 4 categories. Motor of upper.
And what's the difference? There is some difference in for eating, what taking food, is there any thing there? What they are using Japan?
They use the chopsticks.
Here in your study, what is in your what you have assessed in Indian population?
About mixing of the foods and
So you every patient you recorded is eating sadhya.
no, I just asked how they have their food.
Okay, thank you. We are running short of time. Next speaker, please.
Our next speaker is Dr. Abhishek.
Good morning, I'm Dr. Abhishek. I'm going to present outcomes in sphenoid-wing meningioma. Sphenoid-wing meningiomas are one of the complex skull-based lesions. They are benign lesions. They're called complex because they usually have a compression and encasement of neurovascular structures like ICA and its bifurcation. And it can encase optic apparatus and cause loss of vision. It can have extension to cavernous sinus causing multiple cranial pulses. And it can always cause bone invasion, and walls of orbit can be involved, resulting in proptosis and loss of vision due to optic nerve compression. The aim of this study is to know the surgical and clinical outcomes in patients operated for sphenoid-wing meningioma. Materials and methods, it was a retrospective analysis of 26 patients from 2014 to 20. We have reviewed case records, pre-operative MRI brain, operation notes, discharge summary of patients. Follow-up period was up to 2 to 7 years. Data collection, basic demographics were taken, and symptoms, we have taken headache, visual deficits, papilledema, diplopia, trigeminal symptoms, exophthalmos, cognitive deficits and seizures. Radiology, we have taken site, group, size of the lesion, extent of edema, margin of the tumor, encasement of vessels, hyperostosis, orbital or supraorbital fissure, or optic canal, cavernous sinus invasion, pituitary or stalk compression. During intra, we have taken the consistency of lesion, arachnoid plane, cleanotomy, optic canal deroofing, optic nerve status and extent of resection. And pathology of these meningiomas, immediate post-op outcomes, 3 to 6 months follow-up outcomes, and anti-epileptic duration in these patients, and recurrence and adjuvant treatment. The mean age of these patients were under 53 to 57 years. Almost equal number of patients, slightly male predominance. Side of the lesion, we had more of left side lesion than right side lesion. Clinical presentation, headache was the most common presentation in most of the patients. We had visual acuity, visual field deficits, papilledema more common in medial age group, groups. And diplopia, 3 patients had diplopia, 1 due to third and sixth nerve palsy, and 1 due to sixth nerve palsy in medial group, and 1 due to sixth nerve palsy in the lateral group. And trigeminal symptoms were more common in middle and lateral groups. And seizures were more commonly seen in medial group, 4 patients, and 1 in lateral group. And cognitive deficits were seen in most of the patients with medial and lateral group. This is a T2 weighted MRI, which is showing huge mass lesion on the right sphenoid meningioma with encasement of vessels with homogeneous contrast enhancement. On the right side, we can see another example which is having where the lesion is extending into the orbit and encasing supraorbital fissure and orbit. This is a post-op axial section and contrast section which shows gross root resection, and the right one is an example to show subtotal resection. In radiology, we have taken size, edema of the lesion, which was seen maximum in medial and lateral groups. Margin of the tumor we have divided into smooth and lobulated. Most of the tumors had smooth circumference than the lobulated one, and the encasement of vessels were seen more commonly in medial groups. And lateral group and middle group had encasement of MCA vessels. Hyperostosis were more common in medial groups. And orbital wall invasion, supraorbital fissure, all these invasions were more common in medial and lateral groups, middle groups. And in surgery, most of the lesions we could approach through a simple frontotemporal or craniectomy. Only 2 patients required orbitozygotomy. And most of the tumors were having firm consistency in the medial group and soft consistency in middle and lateral groups. And there was good arachnoid plane in 5 out of 12 patients in medial groups and 6 out of 6 patients in middle group. And clearotomy was performed only in 4 out of 12 patients. Optic nerve canal decompression was done in 4 patients of 12 patients in medial group. This is the extent of revision. Almost 21 patients of 26 patients have undergone gross total resection. 5 have undergone subtotal, and majority of them were in medial group. Subtotal resection was more in medial group. And this is the pathology. High-grade meningiomas were seen more commonly in lateral group, that is atypical and anaplastic, and most of the medial group were in grade 1 meningioma. Immediate post-op, we have assessed visual acuity, improved, no improvement, and worsened. Only 1 patient had improvement in visual acuity, and 1 out of 3 had improvement in diplopia and in medial group, and 1 in lateral group. And proptosis, trigeminal symptoms were not improved in immediate post-op, and seizures were controlled in all the patients. At 3 to 6 months follow-up, 1 patient had worsened to bilateral PL negative, 1 patient improved to 6/6, 2 patients had no improvement, they remained in 6/24. And diplopia improved in most of the patients, proptosis also improved in all the patients. Trigeminal symptoms improved in 1 patient in middle group, lateral group there was no improvement, but had recurrence of seizures in 2 patients in medial group and 1 patient in lateral group. Medial group and lateral group had longest duration of antiepileptic duration. Medial group up to 5 years and lateral group up to 2 years. Middle and end plague we could taper and stop it by 3 to 6 months. Radiation, 8 patients have undergone radiation depending on their pathology status and the subtotal resection status. And 4 patients have undergone radiation 3 months post-op, 1 patient at 6 months post-op, and 3 patients at 1 to 2 year post-op. Recurrence was seen mainly in the gross total resection patients. Subtotal resection patients were kept under follow-up. And in gross total resection patients, at 2 years, in the medial group, at 2 years, 1 patient had recurrence and radiation was given. Another patient had recurrence at 4 years and he lost a follow-up. Middle, there were no recurrences. And lateral, at 3 years, 1 patient had recurrence and redo surgery was done. And at 5 years, 1 more patient had recurrence and redo surgery was done. So in lateral group, most of the patients we have taken for redo surgery. In medial group, we have given radiation. The take-home message is sphenoid meningiomas are one of the complex skull-based lesions because there is always a risk of injury to optic nerves, multiple cranial nerves, and vascular structures during surgery. So good microsurgical techniques is very essential for a good outcome. And very high chances of progression of these lesions are there because of residual lesion and high-grade meningiomas. And adjuvant treatment is there whenever there is subtotal resection or high-grade meningioma is there, always go for adjuvant treatment. And strict follow-up of these patients are required because a small growth in recurrence in the lesion can cause cranial nerve palsies or visual deficits.
Nice presentation. So, what grading did you consider for the surgical resection?
Grading in terms of
resectability.
Sir, small nodular residue or gross total resection post contrast was taken as gross total resection. Any gross residue in the op cavity was considered as subtotal. We usually do MRI with contrast 3 months post-op.
Was Simpson's grading considered?
No, sir. Simpson's was not considered. We just divided into gross total and subtotal resection.
The radiation therapy group, like what were the histopathology? Like were all
yes, sir. Like for example, if the patient is having grade 1 meningioma with subtotal resection, we keep them under follow for 3 months, 6 months like that. If there is any recurrence, we always go for radiation. High grade meningiomas, even if it is gross total resection, if it is anaplastic, we directly go for radiation at 3 months.
What about proliferation index?
Ki67 mitosis both were considered. Mitosis more than 4 to 19 was considered in grade 2 and more than 20 was considered as grade 3. Ki67, there are variations, multiple variations that is not strictly taken into consideration.
It was not considered. Even grade 1 meningiomas with...
we have taken an analysis, but for outcomes and this recurrence we have not taken. So mainly mitosis and its features, histopathological features.
Okay.
Because there are grade 1 meningiomas where key 67 is 6, 7 and all. So we are not taken. Mainly mitosis.
Thank you. Now coming to grade 1 meningioma, you said if it's a subtotal resection and you give radiotherapy.
No, sir, we keep them under follow. We see how 3
and
months.
when do you decide for radiotherapy?
We see if the patient is amenable for redo surgery, we always go for redo surgery. If the patient is not amenable and if the lesion is around the important structures, then we go for radiation. First, a redo surgery is always considered. If not amenable, then radiation.
Okay. Now coming to the take-home message that you mentioned, there's nothing new in that. Obviously, everybody knows, you have to do microsurgical technique if there's a progression. So just one question I need to ask you. You said in your study, the medial placed tumors were soft and the lateral ones were firm.
No, medial was firm.
Firm and the lateral one was soft. So any reason that you could think of? Did you think why it's like that? I don't know. That's what I'm asking.
No, sir. Most of our
anything in the literature to suggest that medial ones are firm and lateral ones are soft? Anything like that?
No, sir. There's no such literature, but in our study we have found out.
What are the points that make you think that it is not amendable to surgery in a sphenoid meningioma?
Sir, if it is going into the optic foramen, we it's always do the deroofing, optic nerve decompression, but still if it is not like if it is involving multiple cranial nerves or into the cavernous sinus, we always.
Cavernous sinus is not amendable.
It is amendable.
Sure.
Yes, sir. Cavernous sinus.
No, it is amendable.
It's amendable for.
A small announcement from the organizers. All the presenters of the free paper session are supposed to take the association membership. Those who have not taken the membership will not be considered for award consideration. So please contact the secretary or treasurer for taking the membership.
Our next presenter is Dr. Nitin Das.
Very good morning. My topic of presentation is prospective observational study on outcome after decompressive craniectomy in patients with moderate and severe traumatic brain injury. So morbidity and mortality of patients with severe traumatic brain injury is very high, and it is a leading cause of mortality and disability across the globe, with low and middle income countries facing the greatest disease burden. So the brain swelling and the intracranial hypertension are well recognized secondary insults associated with increased mortality and poorer outcomes. And approximately 60% either die or survive with a severe disability, and in 10 to 15% of the patients with severe traumatic brain injury, raised ICP is refractory to medical management, mannitol and hyperventilation. So decompressive craniectomy is recommended in such cases for lowering ICP to minimize the secondary brain damage. This involves removal of a part of the calvarium with lax duroplasty to create extra volume and reduction of the ICP. And it improves oxygen delivery to the brain cells by improving the blood flow. And it is still unclear whether the decompressive craniectomy improves the functional outcome in patients with severe TBI and refractory raised ICP. The objective of the study, the primary objective was to study the neurological outcome using extended Glasgow outcome scale of patients undergoing decompressive craniectomy for severe and moderate traumatic brain injuries at a tertiary center, serially at the time of the discharge at 1 month and at 3 months post-discharge, and to study the factors affecting the neurological outcome in patients undergoing decompressive craniectomy for moderate and severe traumatic brain injury. Methodology. An institution-based prospective observational study done in a government medical college on a total of 61 patients, and patients undergoing decompressive craniectomy for traumatic brain injury were included in the study after proper informed consent. Patient's neurological outcome was determined with the extended Glasgow outcome scale at the time of discharge, 1 month after discharge and 3 months after discharge, and extended Glasgow outcome scale of 5 to 8 were considered as favorable outcome, while 1 to 4 were considered as unfavorable outcomes. The intraoperative view of the frontotemporal decompressive craniectomy flap that we took, and a lax two-layer G-patch duroplasty was also done. Secondarily, inferential analysis was done for the following: age less than 60 years and more than 60 years, the mode of injury, road traffic accident and others, and time of injury to intervention less than 3 hours, more than 3 hours. Preoperative GCS or 9 to 12 were classified as moderate and 3 to 8 as severe traumatic brain injury. Preoperative pupillary anisocoria were present or not. Preoperative CT findings and midline shift was assessed whether more than 1 centimeter or less than 1 centimeter. Duration of hospital stay was also considered for categorized into less than 2 weeks and more than 2 weeks. Postoperative complications of infarction, postoperative brain infarction, hydrocephalus, and whether a tracheostomy was performed or not performed were also assessed in the study. This was a prospective observational cohort study to see the functional outcome in patients following decompressive craniectomy due to traumatic brain injury. The primary measured outcome, the extended Glasgow outcome scale after decompressive craniectomy in moderate traumatic brain injury and severe traumatic brain injury, measured at discharge 1 month and 3 months were follow-up were. So the outcome score is 1 we are giving status of death, 2 is vegetative state, 3 is lower disability and upper disability. This is classified as a poor unfavorable outcome, and lower moderate disability, upper moderate disability, lower good recovery and upper good recovery, categorized as 5 to 8 were classified as favorable outcomes. So it's a table showing distribution of extended Glasgow outcome scale at discharge at 1 month and 3 months of follow-up. So at 3 months follow-up, 49% of patients undergoing traumatic decompressive craniectomy had a favorable outcome. This is a chart showing status of the patients according to extended Glasgow outcome scale at discharge at 1 month follow-up and 3 month follow-up. So 25 were in the category of favorable outcome at the time of discharge, at 1 month 28, and at 3 months 30 out of 61. Relevant variables with unfavorable functional outcomes were found out to be age more than 60 years, a pre-op GCS of less than 9, pre-op pupillary asymmetry present, and development of post-op brain infarction. This is a chart showing distribution of age based on extended Glasgow outcome scale at 3 months, and in this we can see for age more than 60 years out of 21, 15 were 15, that is 24.6% were in the unfavorable outcome. In distribution of pre-op GCS based on extended Glasgow outcome scale, 18 out of 26 came in the unfavorable outcome category. Distribution of anisocoria based on extended Glasgow outcome scale at 3 months, 22 out of 31 were in the unfavorable outcome category. And in the development of post-op infarct, 6 out of 7 came out to be in the unfavorable category. So decompressive craniectomy is considered a salvage surgery for severe TBI patients, and it is associated with a high morbidity and poor functional recovery. In our study, 49.18% of the patients following decompressive craniectomy had a favorable outcome, and it's a comparable to and better than outcome data from many international studies. And decompressive craniectomy in traumatic brain injury is associated with a reduced mortality, but it continues to be associated with poor functional outcome in half of the patients. Age, pre-op, GCS, anisocoria, and post-op brain infarct are significant outcome predictors. So the major challenge in the management of head injury is, especially in the developing countries, is prevention, pre-hospital care, and rehabilitation in the developing countries. Our limitations were a short sample size and short study period, and this experimental studies may be limited by ethical issues, and multi-center large population studies are required. The main randomized trials in the field of decompressive craniectomy following TBA are 3 in number. They are the DECRA trial, the rescue ICP trial, and the rescue acute stage trials. Thank you.
You told about infarct. I mean, which territory infarct? You said patients with infarct did bad.
Most of the patients we following trauma, we had a posterior PCA infarct and MCA infarct were seen most commonly. Also, PCA infarct was also common.
You saw MCA infarct?
One or two studies, sir. But PCA infarcts were the common.
PCI is explainable, ACA is explainable, MCA, I don't know how.
So, PCA was common.
Did you have MCA infarcts?
One patient, sir.
Okay, the other thing is that your take-home message, I mean, there's nothing new, you know, it's just common sense, older people, people with dilated pupils, massive brain shift, delay in surgery, all these are poor prognostic features. So compared to the DECRA study, you know, the mortality is reduced, but functional outcome did not make much of a difference. So there's nothing new in the study that you presented. Any comments?
This is a very, what type of patient you take for decompressive craniotomy? What is your indication?
At the time of admission, our indication is only a low GCS patient with
that is GCS below?
So moderate to severe traumatic brain injury. That's a GCS less than 12.
You take for decom.
GCS less than 12 and
GCS less
and
than 12 you take.
And that is one criteria. And then other CT findings of the patient.
What CT findings?
So if an acute STH, if it's a significant mass effect, we'll consider for a decompressive craniotomy.
What do you mean by significant mass effect?
Midline shift, the effacement of the cisterns, midline shift more than 5 mm.
You said it is a 10 mm.
Yes, sir.
Add up Marshall's grading.
Yes, sir?
Marshall's grading. Marshall's grading.
Oh, Marshall's grading?
I don't want. Because you said this less than 12 is unacceptable. A patient with a thin subdural primary injury, a patient can come with a 12 score and he doesn't have a rise ICP.
Yes, sir.
Then why you take him for a decom?
Sir, the GCS less than 12 is one of the factors that we consider. That other CT findings and the pathoanatomic classification will also favor.
You are not bothered about the ICP, all the findings.
Features of raised ICP, we can, in our tertiary care settings, there is ICP monitoring per se. We are not able to do that in the ICP monitoring. We are, it is based on the clinical.
Why can't you do this? Why can't you do the ICP monitoring?
The neuro monitoring and ICP care is
it's not that costly. Comparing the other gadgets in our hospital, it's not that costly. Because when you see the patient with the dilated people who are already in a danger state.
Yes,
so already the damage has occurred.
Yes, sir.
That's why you are getting infarct. You do a preempting strike. That before the patient go for a herniation, you should do the necessary things.
Yes, sir.
Okay.
Next speaker is Dr. Sainath.
Good morning, everyone. Today my topic is comparative analysis of trigeminal neuralgia caused by arterial and venous compression. This is our institutional experience of like clinical features of both arterial and venous and surgical outcomes in 200 cases. Introduction is, as everybody knows, that trigeminal neuralgia is a common disorder characterized by paroxysmal provocable unilateral facial pain, mainly in the distribution of trigeminal nerve. According to the literature, the incidence of trigeminal neuralgia is 10 to 182 for every 1 lakh population, and it gradually increases with age more than 65 years. The established concept is the neurovascular conflict was first described by Dandy in 1934, and it is widely accepted from 1934. And the treatment of arterial compression of trigeminal neuralgia, the MVD was also an established concept, but the clinical features and outcomes from venous compression was not well established. So my main objective of my study is to explore the differences and clinical features and surgical outcomes of trigeminal neuralgia patients with mainly the venous neurovascular conflict and combined arterial plus venous neurovascular conflicts. Methods from 2014 to 2022, almost 200 patients suffering from TN were treated in our neurosurgery department, and after the ethics committee approval, data was collected retrospectively. And preoperative detailed clinical evaluation, including the type of pain and MRI brain, including the CIS sequence, and the surgical outcomes based on the Barros Neurological Institute pain score were evaluated at 2 weeks post-op and 6 months post-op period. The inclusion criteria were the patients suffering with trigeminal neuralgia with arterial or venous or both arterial plus venous compression were enrolled in our study. Exclusion criteria were inadequate radiological images, and there were no compressive findings seen in intraop and bilateral trigeminal neuralgia, and who had undergone previous microsurgical treatment for trigeminal neuralgia, and secondary trigeminal neuralgias were excluded. And the neurovascular conflict was mainly identified based on the intraop findings, not on the MRI. Clinical symptoms, neuroimaging characteristics, intraop findings, outcomes, and complications and recurrences were recorded. As everybody know that the standard surgical procedure is microvascular decompression. It is done under neurophysiological monitoring, and a standard suboccipital retrosigmoid craniotomy was done. And after dissecting the arachnoid around the nerve from the brainstem, that is the root entry zone till the petrous segment, after dissecting the arachnoid around the nerve, we identified the type of neurovascular conflict based on this, like this. Either it is superolateral compression or supromedial compression or inferior compression, and the location of the conflict was also identified. That is divided into three: root entry zone, a mid-cysternal segment, and at the petrous region. And a standard Teflon sponge was used after dissecting the offending vessel from the nerve to place in between the offending vessel and the nerve. The outcomes, as I told, evaluation was done at 2 weeks and 6 months post-op. 2 weeks was taken as short-term outcomes and 6 months was taken as long-term outcomes. This is clearly based on the Barras Neurological Institute Pain Intensity Score, which consists of 5 grades. First grade is taken as a successful outcome, and more than 2 or equal to 2 was taken as a failure outcomes. This is the basic demographic data of this 200 patients. Out of this, 99 were female and 101 were male patients. The median age in our study was 62 years, and more commonly we have seen on the right side involvement. And the topography of facial pain in our study mainly observed was V3 distribution was more commonly involved, that is 44%, followed by V2 plus V3. And most of the patients has type 1 type of pain, and the mean duration of pain was 33 months. The patients of MVD pre-surgery, out of 200, 171 patients were taken carbamazepine, and 42 patients were on baclofen, and 95 were on gabapentin, and 55 were on amitriptyline, and 12 patients out of 200 they had undergone radiofrequency ablation from elsewhere, and in 2 patients there are no previous treatment was taken. All pre-op MRI images were, we tried to identify the neurovascular conflict. In the 200 patients, in 9 patients we didn't find any neurovascular conflict on the pre-op MRI, and location of the neurovascular conflict was 124 in root entry zone, and 73 in mid-cysternal, and 3 were at the petrous. Most common site was identified as supromedial, that is 106, and in suprolateral 72 and inferior 44. The short-term outcomes were like this. Successful in, that is a 2 weeks evaluation, 141 has a BNI of 1, that is no pain, and 59 patients had some amount of pain. And on the long-term follow-up, the success rate has increased to 171, and failure was identified in 12, and delayed cure is identified in 16. Delayed cure is the patient who had a BNI score of 2 at immediate post-op, which improved to BNI of 1 in a delayed, maybe at 6 months and 1 year. A recurrence was identified in 1 patient who had a BNI of 1 post-op, and it came back to the BNI score of 4 at 1 year. This is a comparative analysis of trigeminal neuralgia patient with different types of NVC. Most of them were presented with arterial compression, that is 161, and venous was 20, and combined was 19. And age group 61.75 in arterial and 60.4 in venous, and in both combined groups it was 51. So almost arterial and venous has both has around the same age group, and the pain duration was slightly more in arterial group, that was 35.15, and in the venous group it was 26. In the combined group it was 27. And in the venous group, most commonly we have seen on the right side, and even in the arterial also is on the right. And the pain distribution, mainly in arterial group it was 66%, that is 40.9% in V3 distribution, and 65% in the venous distribution. So more commonly V3 points towards the V3 involvement in the venous group. Type 1 pain was most commonly seen in arterial and both the venous groups. And the location was more common of root entry zone in arterial, and in venous also it was arterial, that is around 65%. And in the cisternal segment was 59 in arterial and 7 in venous. The outcomes were like this in comparison. In arterial group, more commonly we saw it is involving the superomedial segment, and in the venous group it is mainly involving the inferior. As everybody knows that the trigeminal neuralgia somatotropic organization is the V1 will traverse medially, and the V3 will be inferiorly and laterally, and the V2 will be in between the V1 and V2. And the compression, according to the compression, mild, moderate and severe was taken. This is according to the Japirus classification. Mild was, the artery was just abutting the nerve, and in the moderate group it is compressing. In the severe group it caused an impression on the nerve. And when it's in comparison, in the arterial group was morely it was like mild, and in the venous group it was also like mild compression was noted on 16 patients out of 20. Coming to the outcomes, in arterial group the success was established in 119 patients at short term, and in the venous it was 10, and in the long term it was 141 in arterial, and venous it was 17. In the venous group we observed there was a delayed like success score, that is at 6 months. In the arterial group the immediate outcome is it was there at 2 months. The take home message is the venous compression is mainly, it involves the inferior and laterally compression, and the mean duration will be almost same in both the patients, and the severity of compression is mild in venous group and in the moderate to severe in the arterial group. Why means venous might be having the low venous pulsations, and because of a thin vessel wall it might be causing the mild compression. Thank you.
You got time for one question. Like the failure rate was high in venous compression group?
Which one?
Was the failure rate high in venous compression group?
In the immediate outcome assessment at 2 weeks, the failure rate was high in venous group, sir. But it picked up in the 6 months follow-up group, sir.
Were the images reanalyzed or retrospectively visualized in the failed group patients? Or
Actually,
did you go back and see why these patients failed?
My explanation for this is venous compression, the compression is mild, but the outcome delays, there is a delay in the outcomes at 6 months.
Okay.
Our next speaker is Dr. Ahmad Shamil.
Good morning all. Today my presentation is about ossification of posterior longitudinal ligament of cervical spine. Single institutional experience on surgical outcome. Coming to the introduction, ossification of the posterior longitudinal ligament is a condition comes under endosopathies causing abnormal calcification of OPLL, and the most common location is the cervical spine. Compression of the spinal cord lead to neurological symptoms. The male-female ratio is 2:1. And the common presentation is in 5th to 6th decades. And the most common location is cervical, 70%, and thoracic and lumbar corresponds to 15% of cases. This management of the OPLL, it includes both conservative and surgically. Coming to the pathogenesis and risk factors, it is common in Asian population, especially in Japan, China, and Korea. The exact pathogenesis is still unknown. Genetic, environmental, hormonal and lifestyle factors have been reported as causative factors. Human collagen type 11A2 gene located in chromosome 6 and type 6A1 gene in chromosome 21 could be a responsible gene for this OPL formation. And other factors like non-insulin dependent diabetes mellitus and high bone mineral density is also a non-independent factors. This is the types of OPL, so continuous, segmental, mixed and focal. The clinical manifestations will be cervical radiculopathy or myelopathy, axial neck pain or restriction of the neck movements. And the diagnosis include cervical spine lateral X-ray, CT scan of neck and MRI of the cervical spine. Surgically we can approach either anteriorly or posteriorly. Anteriorly we can manage by corpectomy and fusion. And indications for anterior approach is the kyphotic deformity. We can assess by the K line. K line is the line drawn from the midpoint of the C2 canal, spinal canal to C7. If this OPLL crosses the K line, we call it as K line negative. And if it is located ventral to the K line, it is K line positive. So indications, that is kyphotic deformity, K line negative group, segmental type and also limited corpectomy maximum up to 3 levels. And occupancy ratio more than 60%. Occupancy ratio is the ratio between the distance between the OPLL and the spinolaminar line to the spinal canal diameter. If it is more than 60%, we will go for an anterior approach. Posterior approaches, we can go either laminectomy or laminectomy with fusion and or laminoplasty. Indications are continuous, long segment OPLL, K-line positive cases and occupancy ratio less than 60%. My objective of this study is to determine the surgical outcome of anterior and posterior approaches for cervical OPL. And it was a prospective study, and study population those patients who had undergone surgical intervention for cervical OPL. And the study period is from January 2020 to December 2021, and the sample size is 24. And the parameter I used is the modified Neurick's grade. It was assessed preoperatively and 6 and 12 months postoperatively. Findings in my study, the mean age group is 51.4. The majority of the patient comes under 51 to 60 age group, and second is the 41 to 50. And the male-female ratio is 19:5. And mean duration of symptoms, sensory it was 7.2 months, motor 8.2 months, and 2 patients had bladder involvement. And type 2 diabetes mellitus was present in 15 patients, that is 62.5%. And the mean preoperative Neurick grade was 2.82. In my study, 10 patients had continuous type of OPLL, and 5 patients had mixed and segmental in 9 patients. And 9 patients had undergone anterior approach, and 15 patients had undergone posterior approach. In my analysis, 3 patients remained static, and 3 patients' neurological status deteriorated. In which 2 patients had undergone laminectomy and 1 patient had undergone corpectomy. And the post-op Neurick grade, after 6 months it was 2.18, and 1 year it was 2.07. Both have a p-value of less than 0.05, which is significant. And 1 patient who had undergone corpectomy had surgical site hematoma, where we did re-exploration, and patient went well. And this is a chart showing about the details of patient. Conclusion, surgical treatment for cervical OPL is very effective in improving the functional outcome. Both anterior and posterior approaches can be done safely. Thank you.
Thank you. So what is the message you are trying to say? What is new?
So one thing is that the incidence rate of OPL is very high in my study, because in literature it's showing OPL due to myelopathy due to OPL is only nearly 5%. In our institution, during this same period, we have done 98 cases of myelopathy, surgeries for myelopathy other than OPL. So there is a
No, I didn't understand. Can you repeat that?
actually in OPLL, myelopathy due to OPLL, the total percentage is nearly 5%.
So if 100 people have OPLL, only 5 have myelopathy.
No, no. In all cases of myelopathy, 5% of myelopathy is due to OPLL.
Okay.
So another thing is that in my study there is an in our institution we have done 98 case of surgery for myelopathy other than OPLL, and also during the same period we have done surgery for 24 patients of OPLL cases.
Okay, so it's about 24%. Among all myelopathy, OPLL incidence is 24%.
Yeah.
In your study, that's quite high. So maybe the other causes of myelopathy are not coming to your institution, or is it something specific? The other thing, do you have absolute indications for anterior or posterior approach?
One is the segmental type, and in patient is having kyphosis.
Because you have mentioned some indications for each. I am wondering whether it's absolute or relative.
So long segment, we won't go for an anterior approach.
Maybe judges, you all have been silent.
Depends on the clinical
supposed to remain
situation.
silent, actually.
Just a question. What is your indication for surgery in OPLL?
So progressive myelopathy.
How will you assess the progressive myelopathy?
If patient
deteriorating neurics period, deterioration neurics, or something else.
OPLL may present as asymptomatic or symptomatic. If the symptomatic cases, if the neurological status, if the patient is having any features of myelopathy, we have to go for surgery.
At the first chance when you see patient with a myelopathy and OPL, they may go for surgery. At the first chance you see a patient with a myelopathy, you straight away advise him surgery.
Depend based on the MRI findings also. If the
what is the natural course of cervical spondylotic myelopathy?
Some patients may become static. Some patients may become symptoms may improve. Some patients have progressive neurological deficiency.
Without surgery?
No. So without surgery, some patient may become symptomatically better.
So you first said patient with all myelopathy, you go for surgery.
Based on the clinical findings and.
Okay, what clinical finding?
Human findings.
The patient should be in your follow-up. So patient come with a myelopathy. Suppose a patient with a OPLL comes with a sudden deterioration. Sudden deterioration means he has moving around. He can do his daily routine himself. What will you do? There is some deterioration, some power or some increase in spasticity. What will you do?
We have to reassess the patient by using MRI and.
Have you checked the canal dimension in deciding whether patient go for anterior or posterior approach?
That is occupancy ratio, is there?
Taken.
Yes.
Before treating any disease, you should know the natural cause. The patient coming to with some deterioration, minor deterioration, you don't advise him surgery. You can observe, wait.
Thank you, sir.
Thank you.
Thank you, sir.
Our next presenter is Dr. G. Ajayan, Consultant Neurosurgeon, Gokulam Medical College.
Respected chair, my teachers, friends. This is only just a case report rather than. I need to press this only. 42-year-old carpenter presented to the surgical OPD with a small swelling in the armpit. It was about 2 into 3 into 2 centimeter size, but it had a very irregular surface and irregular margin. With a provisional diagnosis of matted lymph node, they initiated investigations, and admitted in the ward. Next day, in the surgery clinics, when this case was presented, somebody found when it is being pressed from some angle, there is an electric-like feeling in the front of the forearm. So, changing the diagnosis to neurofibroma, they send the patient to the neurosurgery side, where by that time they have initiated all the investigations like FNAC, then chest X-ray, MI-endo, etc. But the FNAC yielded some infective fluid, and it came as cystic, and ultrasound also yielded results like a cystic swelling. Also, they were counseled such that you don't go in for surgery because it may result in some injury to muscles, nerve, and result in loss of power, and that may affect his career. But this man insisted for surgery, and that would have been the reason why the patient has come to neuro. And on ultrasound, we could find that there is a swelling which was more in size, like 3 into 4 into 2 centimeters, and it was jetting between the biceps and the posterior group of muscles. So anyway, we planned for MRI. MRI also yielded the same, and the cystic swelling which is being shown, and they were also of the opinion that it's almost the same size. It has got, but their comment was that there was no relation with any neurovascular structures. Okay. But Thinnell sign, which bothered us a lot. We were scared of proceeding with surgery, but the patient had some problem with his movement, that he was not able to do his profession properly. That was his main issue. In that context, we planned for surgery, and during surgery, before that, we consulted the anatomy people also. They were talking about, this was more of, our opinion was this was more of C6 dermatome, but they were of the opinion that it could be C8. Two things they were coming, 2 points with which they were coming up was that this Thinnell sign was positive, not involving the whole of a dermatome, only a part of the dermatome. And they were saying that the C8 terminates as strings and such that only part need be involved. But if it is C6, it comes through the musculocutaneous nerve, and it may involve the whole of the dermatome. That was there, I don't know, we could not check up with much textbook or anything like that, but it would have been their derivation. But anyway, we planned for surgery, and we could see like this, a cystic swelling, which was almost translucent, but it had some attachment to a structure in the posterior part. On dissection, we found a strand-like structure like this, the wonderful nerve, but we could not trace which one. But still, we left a part of the cyst there, broke that cyst out and drained the fluid and took the capsule and sent for histopathological examination. It has come as schwannoma. So, on workup, schwannomas degenerate into hemorrhage, calcification, fibrosis, but cystic degeneration is very rare. And to conclude, I would like to bring in a take-home message for students, PGs and juniors, that when a clinical sign stands out, we should give weight to that and all the other investigations. Because the radiologist was ready to aspirate it and inject some sclerosant into the swelling with the hope, with the impression that it is only a lymph cyst. But the finding made us go for surgery, and we could save the nerve also. Shall I conclude? Thank you.
Thank you, Dr. Gopalan. Yeah, it's a rare case. The anatomist, I don't think there was any need to split the hair, whether it's C6 or C8. I mean, a cystic thing sitting there close to the brachial plexus could catch any nerve root and irritate any nerve root. So obviously, that was the cause of the symptoms, whether it's C6 or C8, doesn't matter. I don't know why the radiologist, in the presence of a compressive symptom, injecting sclerosant will not help relieve the compression.
No, what they were saying is that no, they will drain the whole fluid and inject some sclerosant such that the covering, I mean the membrane will get attached to each other and it will get collapsed. This was their way of approach. And interventional radiology always is being helped out by the other department, I mean administration and all. They were proposing that.
Okay, maybe that works, I don't know. I think this one judges can open up, no problem. It's not a competition. Yes, sir.
How reliable is this delineation of dermatomes? Are there not very common overlaps? How can we pinpoint C6, C7?
No, sir.
Correlating with the clinical aspect.
Actually, the patient was complaining of this electric feeling in the midline of the forearm, anterior part of the forearm. And when discussed with the anatomist, now we were reaching a situation where either it can be C8 or it can be C6. But to us, C6 being a higher root and C8 being a lower root, we were much more happy to go with their finding that it is C8. Actually, I don't know how for your question, I don't know anatomically how can we differentiate.
No, here actually you are not dealing with roots. No, it's in the brachial plexus.
No,
right?
sir. No.
You are looking
the
at
ultimate
cords
result.
and the branches.
No, the post-operative complications, as well as the patient was already counseled in such a way that it is going to produce some muscular weakness, and the patient is going to have some finding.
I know, but like Dr. Srikumar is saying, you know, it's not a question of roots here. Roots are at a higher level.
Sir.
This is in the axilla where all the cords and branches have all come, lot of overlap of root values, you know. Every branch has a C6, 7, 8, T1 root value.
Okay, sir.
So there's a lot of overlap there. So.
Jane, it is a rare case, but the clinical examination, you say, I think you told surface was irregular.
And I could listen to only the last few part of your lecture.
Irregular surface.
Yeah, and it seems you have operated on a C6 or C8 root schwannoma, I am not very sure. But I totally disagree with Harun's comment saying that it is immaterial whether it is arising from C6 or C8. You have to know, if possible, from which root it is arising, so that you know, you can counsel the patient. In the event you have to sacrifice that root, you have to tell these deficits and come. So it is our duty to know, at least clinically, at least sensory, reflex and motor wise, whether we can pinpoint to a root, or even distal to the root cord or whatever it is. Because I couldn't listen to most of the lecture. Anyway, good lecture. Okay.
Yeah, I think the problem is that this is not a root issue. This is not a cervical spine issue. This is in the axilla. This is after all the branches have come out.
All the more important. Because Sir was telling in a root there can be some overlap. But more distally, if you damage means gone. So you have to know whether from where it is arising, whether root or cord or from where nerve. You have to find out that. Now, very important. Clinically, it's very important.
Okay, Dr. Devdas.
Just for the information of postgraduates, whenever there is tinal sign, strongly suspect that there is some neural compression. Either it is either touching the nerve or it is involved the nerve. That is one. The second thing is, in a neurofibroma or a schwannoma, generally along the axis of the nerve, there will be no, the movement will be perpendicular to the nerve, but on the long axis of the nerve, there won't be movement. That is another clinical point you have to look into. In the long axis of the nerve, there won't be movement, but in the transverse axis of the nerve, there will be movement. That is the second point. The third point is, if you look at the MRI images, it's a plain MRI, there is a fluid level suggesting high protein content. That is one other point. Fourth thing is, whenever you are going for an MRI, always insist on a contrast MRI that will delineate nerves better.
Thank you. Thank you very much.
Sir, thank you very much.
Our next presenter is Dr. Shinaz Hussain.
Good morning all. Neurotization in brachial plexus injury, our experience. brachial plexus injuries are devastating injuries which actually leaves a patient with a functionally useless upper limb. Neurotization surgery focus on the reconstruction of the injured nerves of the brachial plexus, and it is very effective treatment among all other treatment modalities. We are hereby sharing our experience of the same procedure in our institution. Aims to analyze postoperative motor outcome in patients who underwent neurotization procedure for brachial plexus injury, and to analyze predictors that determine the postoperative motor improvement. Materials and method. It's a retrospective study which was conducted among 22 patients with post-traumatic root avulsion brachial plexus injury who underwent neurotization surgery between 2014 and 2022, that is over the last 8 years. Inclusion criteria: irreparable injuries to the upper spinal root, that is C5, C6 and C7 roots, and surgery must be done within 3 to 12 months following injury, and patient should be followed up for a minimum of 6 months. The preoperative workup include detailed history and clinical examination, MRI of brachial plexus with screening of the cervical spine, and evaluation to rule out any associated bony, ligamentous or vascular injuries, and nerve conduction studies and EMG was also done prior to the procedure. The goals or aims of surgery in order of the priorities as follows: the restoration of elbow flexion, restoration of the shoulder abduction, and lastly the restoration of sensation along the medial border of the arm and forearm. These are the aims of the surgery. Coming to the surgical techniques, neurotization actually refers to transfer of a proximal, functional but less important nerve to a distal but more important denervated nerve. For upper brachial plexus injuries, we use the following 4 procedures in combination. For restoration of shoulder function, we use spinal axillary nerve to suprascapular nerve anastomosis. Somsack procedure, where a branch of the radial nerve that supplies the long head of the triceps is anastomosed to the anterior division of the axillary nerve. For restoration of elbow function, we use Oberlin procedures, where the fascicles from the ulnar or medial nerve transfers to the musculocutaneous nerve, and also intercostal nerve, that is 3rd, 4th and 5th intercostal nerve anastomosed to the musculocutaneous nerve. Brief about the surgical techniques. In spinal axillary nerve to suprascapular nerve neurotization, the branch of the spinal axillary nerve that supplies the trapezius is divided and which is anastomosed to the suprascapular nerve. And Somsack procedure, one of the branch from the radial artery, mostly the branch that supplies the long head of the triceps, goes to the anterior division of the axillary nerve that supplies the deltoid muscle. You can use either of this procedure to restore the shoulder function, but the literature says that the double neurotization procedure using 2 techniques gives the better results. For Oberlin procedure, it is a classic for restoring elbow function, where 1 or 2 fascicles from the ulnar or medial nerve dissected, and it is anastomosed to the musculocutaneous nerve branch that supply biceps brachii and brachialis. When the ulnar nerve is used as a donor nerve, it is known as Oberlin 1 procedure, and when the median nerve is used, it is known as Oberlin 2 procedure. In Oberlin procedure, it involves only a short segment anastomosis, and both donor and recipient nerves are of same caliber, and thereby it used to give better results. You can also use intercostal nerve, that is 3rd, 4th and 5th intercostal nerve to musculocutaneous nerve for restoring elbow function. It is of more useful when there is global brachial plexus injury, where we could not harvest any donor nerves from the injured brachial plexus on the same side. Once the donor and recipient nerves are coapted without tension, the nerve anastomosis is done under microscope using H0 proline, and tissue glue is applied in all cases. In our series, for shoulder function, spinal axillary nerve to suprascapular nerve anastomosis is done in 20 cases, Somsack procedure done in 9 cases. For elbow, we used Oberlin procedures in 16 cases, and Oberlin 1 procedure in 16 cases. Oberlin 2 procedure was done in 6 cases, and intercostal nerve to musculocutaneous nerve transfers was done in 8 cases. These are the details of neurotization for individual cases. We had a series of 22 cases. You can see all the patient had upper brachial plexus injury, and one case of Erb's palsy, that is C5, C6 birth injury, was also included in the series. And you can see that double neurotization used for shoulder function in most of the cases. The time duration for the procedure was for spinal axillary to suprascapular nerve anastomosis, it took 2 hours. For Oberlin 1 and 2, 1 hour each. And for Somsack procedure, it was 1.5 hours. And for intercostal nerve to musculocutaneous nerve transfer, it took 2 hours. The treatment cost was less than 10,000 rupees only. Postoperatively, the flexed arm was strapped to the chest for a period of 3 weeks, followed by gradually increasing physiotherapy and electrical stimulation. And all the patients were evaluated at 3 months interval serially. These are the postoperative image where you can see the significant improvement in shoulder abduction and also the elbow flexion. The postoperative complication, one patient had developed surgical site hematoma which was drained. No other significant complications were occurred in the postoperative period. And the preoperative and postoperative motor power were documented using a modified British MRC scale that where the motor strength ranges from 0 to 5. Coming to the result, we had 22 patients, 20 were male, 2 were female, and the right side was involved in 9 cases and left side was involved in 13 cases. And the mean denervation time, that is the time frame between the injury and the surgical intervention, was 7.5 months. And the postoperative motor results were assessed as per the classification scheme proposed by Tersis et al., where the postoperative motor results were graded from excellent, good, fair, and poor based on the postoperative muscle power. 3 out of the 22 cases got an excellent shoulder function in the postoperative period, and 6 of the 22 case patients got excellent results in elbow function. And 4 patients got good result in shoulder function, and 7 patients had good results in elbow function. We have compared our results with a similar study that was published in 2022 by Lee Singh et al., and the results were compared. The sample size of our study was 22, whereas in Lee Singh et al. Study it was 19. The mean age was comparable in both studies, and the mean denervation time was 7.5 months in our study, whereas in Lee Singh et al. It was 6.7 months. Coming to the results of both studies, the improvement in shoulder function in the postoperative period comparable in both studies, and we got excellent results in shoulder function in around 13% of the cases, and good result in 18% of the cases, whereas in the literature it was 10% and 20% respectively. Whereas in elbow function we had far superior results. We got excellent result in 27% cases and a good result in 31% of the cases, whereas in the corresponding Lee Singh et al. Study it was 0% and 10% only. So coming to the conclusions, brachial plexus injury is a devastating type of injury, and it is neglected many a times due to various factors. And young patients with short intervention time yields good results. And intraplexal transfers and selective neurotization close to the target muscles are associated with good recovery. And the results of surgery together with physiotherapy are rewarding if the surgery is done within the stipulated time period. It is obviously an affordable procedure, and we had done this procedure under the cost of less than 10,000 only, and which is far less when compared to other centers where the cost goes beyond multiple lakhs. Thank you.
Thank you very much. Any comments from those who do brachial plexus surgeries?
Regarding the timing of surgery, in certain cases we see that the recovery occurs spontaneously. Recovery occurs without any treatment. With the time, recovery occurs. So how much time we can wait?
The literature says that as early as we do the procedure, we'll get good results. Once there is definite evidence of root avulsion clinically, radiologically, or electromyographical study, it is advisable to do the surgery at the earliest. And there is we are suspecting a post-ganglionic injury, we can wait for spontaneous recovery. Up to 1 year we can wait. Yes. Yes. In elbow function, we used to do Oberlin procedure where we anastomose the ulnar or medial nerve fascicles to the musculocutaneous nerve. This is actually a short transfer. The axon has to travel a very short distance. That may be the reason. No other risk. Actually, topographically, the motor fibers are located peripherally, and the peripheral 1 or 2 fascicles are split and anastomosed to the musculocutaneous nerve that supplies the biceps brachii and brachialis.
Do you include you neurosurgeons alone, do you include?
No, neurosurgeons alone.
But for if you want other things like transposition of muscle, don't you think that those are good procedures?
If there is no improvement after surgery, we can use the salvage procedure like stent and transfers, orthodesis. These procedures are done by other plastic surgeons.
Anyway, good paper.
Thanks.
Thank you.
Our next presenter is Dr. Manoj Kumar.
Good morning all. The title of my presentation is a comparison between the standalone cage and conventional cage and plate in anterior cervical discectomy and fusion for the treatment of cervical spondylotic myelopathy. Anterior cervical discectomy and fusion is an accepted standard surgical treatment for cervical spondylotic myelopathy. The available options for instrumentation in fusion include standalone cage and conventional cage and plates. However, there is no clear consensus regarding the superiority of standalone cage over conventional technique. So, the objective of our study is to compare the radiological and clinical outcome between standalone cage and conventional cage and plate in anterior cervical discectomy for the treatment of CSM. Coming to the materials and methods, the study design was ambispective comparative study. The study population includes patients who underwent ACDF at 1 or 2 levels for CSM between January 2019 and October 2022 in our department. There were 230 eligible patients who underwent the operation during the study period were enrolled by purposive sampling. Among them, 46 patients who had complete data and were willing to participate were included in the study. The inclusion criteria were patients with the signs and symptoms suggestive of CSM, concordant findings suggestive of root or cord compression on MRI, and failure of conservative treatment for at least 6 weeks. And those with a history of previous cervical spine injury, cervical spine surgery, patients with the congenital anomalies of the spine or ossified posterior ligament, longitudinal ligament, and patients who needed a posterior approach in addition to anterior approach were excluded from the study. So, we had complete data of 46 patients, and out of which 26 patients underwent conventional cage and plate, and 20 patients underwent standalone cage. The surgical procedure include through a right side oblique or transverse incision, reached the anterior aspect of the triple column, and longest colli detached, annulotomy done, and discectomy under microscope done. And after satisfactory decompression of the cord, the end plates were prepared, and we placed the standalone cage or the cage with the anterior plate were placed and fused. The follow-up visits were at 6 weeks, 3 months, 6 months, and 1 year, and annually thereafter. Follow-up cervical spine X-rays were obtained at 3 months, 6 months, and 1 year. These are the preoperative and postoperative images of our patients. The Neuri grade and modified Japanese orthopedic grade scores were used to assess the neurological status preoperatively and at follow-ups. Dysphagia was assessed using Bessa score. The radiological outcomes were assessed using neutral and dynamic X-rays. The criteria used for fusion were movement of less than 2 mm between spinous process of the fused segments and absence of radiolucency between the implant and the bony surface on lateral X-rays. The subsidence was interpreted as migration of cage more than 2 mm into the adjacent bodies. The anterior segmental disease was assessed using criteria proposed by Chang et al. And cervical lordosis was measured at Cobb's angle between inferior influence of C2 and C7. Then coming to the results, we had 46 patients in our study, and out of that 26 patients was in conventional cage group and 20 were in standalone group. The mean age of our study subjects were 46 and 49 in conventional and standalone group respectively, and there were the gender distribution was also similar in both the groups. The baseline clinical variables, we considered comorbidities, presence of comorbidities and smoking habits in each group, and 46% of patients in conventional group and 50% of patients in standalone group had associated radiculopathy, and 16 out of 26 patients in conventional group and 15 out of 20 in standalone group had underwent single level ACDF, then the rest in each group underwent 2 level ACDF. So, the demographic and baseline clinical variables while comparing, there is no statistically significant difference in both groups. The most common operated level was C5, 6 in both the groups, 16 and 10 respectively for conventional and standalone group. The neurological outcome, this table shows the neurological outcome in both groups, and the mean neuric grade and modified Japanese Orthopedic Association score assessed preoperatively, 6 months postoperatively, and final follow-up. We can see there is a significant improvement in neurological status at preoperatively, and improvement in neurological status postoperatively in both the groups, and there is no statistically significant difference, intergroup difference at any point in time. The fusion was achieved in 92.3% of patients in conventional cage-and group, while this was 90% in standalone group, and the difference was not statistically significant. The cervical lordosis and segmental angle in both groups of study was also compared preoperatively, 6 months postoperatively, and at final follow-up, and that also in that comparison was also shows that there is no statistically significant intergroup difference in both the conventional and standalone groups. And coming to complications, transient mild dysphagia was present in the immediate postoperative period in 3 patients in conventional group and 2 patients in standalone group, which resolved spontaneously in 4 weeks. Bassas grading was used for assessing the dysphagia. 2 patients in conventional group and 1 in standalone group had implant-related complications. All of this were screw pull-out. Subsidence was present in 5 patients in standalone group, whereas none in the conventional group showed subsidence, which was significant. Now we could conclude the SCDF using both standalone and conventional cages and plate achieved comparable neurological improvement in cervical spondylotic myelopathy. Although both had comparable fusion rates, cage subsidence was high with the standalone groups. These are the references. Thank you.
Thank you. Any comments from the audience?
Why do you call this ambispective study?
Because we
don't mention anything about this.
Because it is a retrospective and prospective study. We collected data retrospectively. We earlier operated patients' data collected from the case records, and we called the patient back for assessing the postoperative neurological status.
Can you show the picture of a standalone cage in your presentation?
While you're searching for that, I want to make a comment. Search for that. Regarding dysphagia, you said temporary dysphagia. I don't think that has got anything to do with conventional or standalone. It has got only to do with the esophageal retraction during surgery.
Yeah.
So it doesn't.
That was transient.
I don't think that should be a criteria in this comparison. Okay. The other thing that your subsidence incidence is very high in standalone cage, which is very well known. But I think you should have compared the smokers in this and the osteoporotic index by DEXA scan to say that they are both identical bones, sort of osteoporotic wise. That would have been more comparable, yeah.
The one you showed in your slide is a standalone cage? Is that the standalone cage?
This is conventional cage and plate.
You haven't shown the standalone.
The picture is not there.
What type of standalone cage you use? It's just a peak cage?
Yeah.
Peak or some titanium?
We used titanium cage only in our instrument.
Titanium. What is subsidence and telescope? What is the difference between subsidence and...
Subsidence means
it's same. It's same. Subsidence and telescope.
Difference? Actually, I don't know.
I think you mean telescoping, no? Because the cage goes into the end plate. That is telescoping. And subsidence means?
Subsidence means both the
graft crumble under the pressure. That becomes less. Telescopic means the graft pierces the end plate and goes inside. Subsidence means graft crumbles under pressure. So the graft.
Suppose the cage is filled with the bone materials, such things will happen. Cage alone and cage filled with the bone material.
What the basic of why he presented the paper, because when you put a plate and screw, they will add extra scaffolding, extra this thing prevent the subsidence of the graft. But if the graft is, these are all depending on other parameters, bone, quality of bone.
Subsidence is actually the adjacent bone where the graft is attached to. It is not the graft actually.
The graft do not collapse, no, because it's PEEK or titanium. It's PEEK or, unless it's a tricortical, purely tricortical graft. Subsidence also same. Okay, thank you. Next speaker.
Our next speaker is Dr. A.B. Sebastian.
Good morning all. Spinal arachnosis, our experience and review of literature. Coming to the contents, I will be speaking in terms of introduction, study details, case specifications, statistical analysis, review of literature and my conclusions. Coming to the introduction, spinal arachnosis is a relatively rare disease. The incidence is less than 1 in 2 lakh. Arachnosis is a CSF filled cyst adjacent to normal CSF filled spaces, either spinal or cranial. Spinal arachnosis is most commonly extradural and present with features of compressive myelopathy or radiculopathy. Coming to my objectives, to describe a sample of patients with spinal arachnosis and to analyze the clinical symptoms, location of cyst, surgical procedure performed and post-operative outcome in all cases of spinal arachnosis admitted in our institution. Coming to the materials and methods, we have included all operated cases of spinal arachnosis in our hospital, which corresponded to 21 cases. The study period was from 8 years, from January 2014 to June 2022. The study design was a retrospective observational hospital-based study. The factors studied included the clinical symptoms, level and extent of spinal arachnosis, location of spinal arachnosis, whether it's extradural or intradural, dorsal or ventral, comparison between preoperative and postoperative functional status. Preoperative clinical assessment, documentation of functional status by MRC grading, and radiological assessment with 1.5 Tesla MRI spine was done. The mean period of follow-up was 6 months. Surgical intervention performed was laminectomy and excision or marsupialization. Laminectomy was done at the level of maximum cord compression. All these patients were assessed at 6 months post-surgery and their functional status was reassessed. Good outcome was defined as improvement in MRC grading or resolution of sensory deficits. This is the tabulation of my data. Here we can see that majority of the patients had a pre-op MRC grade of grade 3 and post-operatively majority of the patients improved to grade 4 or 5. And pre-existing risk factors were noted in 2 patients. One was a 7-year-old female presented with right upper limb monoparesis, had congenital heart disease, its mitral valve prolapse was there. And one child, 3-year-old male child, presented with quadriparesis, had Down syndrome, who had a cervical level ventrally located spinal arachnosis. Coming to the statistical analysis, the analysis was done using SPSS version 20 and all qualitative data was analyzed with Pearson's chi-square test for significance. This is a bar diagram showing the number of patients under spinal arachnosis. So we can clearly see that spinal arachnosis was common from the dorsal level, that's from the T3 to T7 level, followed by the cervical and lumbar. There's a pie chart showing that most of our patients corresponded to 80.9% had 3 or more levels of involvement, and number of segments involved did not affect the outcome significantly. The p-value was 0.69504. Coming to the location of recurrences, 18 patients had intradural location, whereas 3 patients had extradural location. 12 patients had dorsal level, and 9 patients had ventral location. Patients with extradural lesions, that's 3 patients, underwent laminectomy and excision. Patients with intradural lesions, 18 patients underwent laminectomy and marsupialization of fenestration. The follow-up period was 6 months. This is a statistical analysis whereby showing the pre-op MRC score and post-op MRC score, where we could get a statistically significant p-value of 0.0256, and all our patients improved post-operatively. This is a case scenario of a 47-year-old male with paraparesis, had thoracic level dorsally located cyst. The whole length laminectomy was done to expose the cyst, and total excision was done. This is a 3-year-old male child with quadriparesis who had ventrally located spinal recurrences at the cervical level, and we could see a clearly shining cyst. This is a drop video showing the marsupialization of cyst. Coming to the review of literature, and one study by Pham MD et al. In their study by spinal recurrences in their adult experience, published in Journal of Neurosurgery Spine in 2018. They studied 22 patients over a period of 10 years, and the mean age was 53.5 years. Male to female ratio was 1:3, and most common presenting symptom was back pain, and the location was intradural, followed by extradural, and the other patients, they were inconclusive. Most commonly location was dorsal, and dorsal location was more common than the ventral, and surgical intervention was done in 19 patients. They did laminoplasty with cyst excision 68% of the patients, ligation of pedicle in 21%, and fenestration in 11%. Complication was observed was wound infection in 1 patient. The second study by Garg K et al. Published in British Journal of Neurosurgery in 2016. The study included 11 patients over a period of 4 years. Mean age was 32.9 years. Male to female ratio was 2.7:1. Most common presenting symptom was weakness followed by back pain. The location was extradural. Dorsal level was more common. And the surgical intervention was done in all patients, which was laminoplasty with cyst excision, and corresponded to 91%, and fenestration in 9% of the patients. Our study is being compared with Pham MD et al., their study, and Garg et al. Study. We could see that our study had a follow-up of 8 years compared to 10 years and 4 years by the other study. The mean age of presentation was 36.52. The presenting complaint was weakness, more than the back pain, and male to female ratio was 1.1:1. The location we could get is intradural location was more common than the extradural location, and we did laminectomy and excision and marsupialization cases. Coming to conclude, spinal recurrences is a rare clinical entity. The etiology of spinal recurrences has yet to be precisely determined. All patients with progressive neurological deficits has to be operated. The number of segments involved did not affect the post-operative outcome. Significant association was found between pre-op MRC grade and outcome. Surgery may be laminectomy, laminoplasty, followed by excision or fenestration or marsupialization. The purpose of this study and the accompanying study literature review was to present our case series with the aim to outline a best practice therapeutic approach to treat this rare condition. Coming to the limitations of my study, because of the low incidence of spinal recurrences, it makes it difficult to perform a complex statistical analysis, and conservatively managed patients are not included in my study. Thank you.
Thank you. The paper is now open for discussion.
Very good combined, very good study. Say, for your series and the literature you showed, what were the recurrences on follow-up for those who had just fenestration and marsupialization?
So in our study, we could not find any recurrence because we have them under the follow-up. The patients were followed up for after 6 months of surgery with the post-op MRI spine. A whole spine was screened, but we could not see any recurrence, and all the patients had significant improvement in compared to the pre-op MRC scores.
What is the duration of follow-up?
Our mean duration of follow-up was 6 months, sir. Six months only follow-up was there, sir. Their recurrence rate, sir, not mass. Yes, sir.
Any other comments?
Yes, sir.
They were all confirmed by histology?
Yes, sir. All the cysts which are confirmed by histology are taken in this study, sir.
Space above and below, not marsupial. So somewhere the problem is when it's a very long arachnoid cyst. So the upper end and the lower end should be very well seen, and that opening into the normal subarachnoid space in above and below is important. If you do above alone, sometimes it may get again engulfed. If you do below alone also, it may get engulfed. That is the best way to prevent recurrence. Otherwise, it will come. 6 months, as sir was telling, is a short period.
What is the differential diagnosis for the ventrally situated arachnoid cyst in a child? What will be the differential
close differential diagnosis neuroenteric cyst, sir. Neuroenteric cyst, but that can be differentiated only by pathological analysis, sir. In pathological analysis, if neuroenteric cyst will have a cuboidal to columnar epithelium with areas of cilia and flagella will be seen, but in our arachnoid cyst, it will be fibrocollagenous with EMA positivity will be seen in histopathological analysis. Only that is the way to.
Because the reason is, if you just marsupialize such a cyst, yes, and you are not sure, it will exactly look same like an arachnoid cyst on table. But yes, unless you excise the entire cyst, you are going to have a recurrence in a neuroenteric cyst.
Yes, sir.
That is the problem.
Yes, sir.
Another is, arachnoid will never have a small wall, vessel on the surface. Arachnoid is differentiated from other cysts. Like that, arachnoid doesn't have any blood supply, blood vessel on the arachnoid. When you look itself, you will know whether it is.
Okay. Thank you very much.
Okay, okay, sir. Thank you, sir.
Our next presenter is Dr. Swapnesh.
Good morning, sir. Myself, Dr. Swapnesh Chindalore, and my topic is the comparative analysis of interbody cages versus a tricortical graft with anterior plate fixation in isolated traumatic cervical spine injury patients. ACDF is established a proven surgical procedure for treatment of degenerative spines, cervical spines, as well as for the single level traumatic disc bulges. It decompresses the spinal cord and increases the neural foraminal size as well as the volume. And post-discectomy, fusion can be facilitated by using grafts and implants. And in our study, we evaluated the two different fusion and fixation procedures: the autologous tricortical iliac crest bone graft with a locked anterior cervical plate and a standalone threaded titanium cage stuffed with a cancellous bone. Our aim of the study, it's a prospective study to analyze the safety and efficacy of the tricortical autograft with anterior plate fixation, which is a group A, and a titanium cage filled with a cancellous bone, which is a group B, in the procedure of ACDF in a traumatic spine injury patients. This study is done in Tertiary Care Center and a teaching institute from January 2020 to January 2022, and 24 patients with cervical spine injury with single level disc protrusion is included in our study. And after the clinical and neurological examination with radiological confirmation, patients were planned for ACDF. And after the computer generated randomization, 12 patients were operated with tricortical graft with the plate, and 12 patients operated with the cylindrical titanium cage filled with the cancellous bone. So the inclusion criteria, the patients more than 15 years of age with the cervical spine injury having a single level disc is included. Patient is hemodynamically stable, grade 1 listhesis or no listhesis, and no obvious bony fracture. And excluding the patients of pediatric age group, patients in spinal shock, grade 2 or more listhesis, and hemodynamically unstable patients. So in our study, around 49.8 to mean age of the patients is group A 49.8 and group B is 53.4. And the more common level is C5 to C6 and C6, C7 level. So in all the patients, around 10 patients were neurologically deteriorated, neurological problems was there in group A, and around 11 patients in group B. So the surgical approach, the classical surgical ACDF approach has been done. The horizontal incision taken, deepened in layers to reach to the prevertebral fascia, and the level is confirmed with the C-arm. After confirming the level with C-arm, the discectomy is done, with the discectomy done, and after discectomy done, the dorsal as well as ventral bony edges will be nibbled out, and with the help of a drill and the rongers to make the cancellous bone to come out, and it will help in fusion also. This is the iliac bone graft, tricortical bone graft, which is harvested with the help of mallet and chisel, and this is the titanium cage which we have used as a standalone cage. This is the immediate post-op C-arm pictures. Upper one will be the graft with plate, and screw fixation, which is lateral view and the anterior view, and the middle one is the standalone cage with the cancellous bone in a C5-C6 level discectomy after fusion. Now the clinical and radiological evaluation done by Odom's criteria, visual pain analog scale, activity of union on the lateral radiographs, and overall satisfaction of the patient. This is the Odom's criteria, which showing clinical, radiological as well as the patient's patient symptomatic with excellent, good, fair and the poor results. Radiologically, in the group A patients, the osseous trabeculi bridging the disc space, which is seen in the radiographs, and in the group B, the cage, in the group B where the cage is used, we are using the flexion X-ray, which is showing the interspinous distance less than 2 mm in flexion. These are the post-op patients with plate and screw fixation and cage, standalone cage after 6 months. Visual pain analogic scoring from no pain to 0 to the worst pain 10. We have calculated around the scoring of the patients from mild pain to moderate pain and worst pain. The results, fusion was achieved in about both the groups with the duration of fusion ranging from 3 to 7 months in both the groups, with a mean duration of around 4.6 months in tricortical graft group and 4.8 months in cage group. This is the duration is 3 to 6 months in group A and 3 to 7 months in group B, and the VPA scoring mean of 3 in group A, and group B its mean is 2, and group 2. About 88% patients of ACDF with cage and tricortical group was having excellent to good results, and one patient in each group have the poor results due to the persistent radiculopathy and the neck pain. The neurological improvement, the neurological deficit was present pre-operatively, 10 patients in tricortical group and 11 in the cage group, and there is an improvement in neurological status in all the patients in 6 months of follow-up after the surgery. VPA scoring, there is a significant improvement in VPA score from all the patients except one in each group after the ACDF, and in both the groups after the last follow-up. Complications and patient satisfaction, no intraoperative complication was there, none of the patient having post-procedural neurological deterioration, and there is one graft displacement occurred in group A, which is in cage group. There is an anterior extrusion of cage which requires revision surgery, and about 84% of the patients satisfied with the group A and 92 in group B. Now discussion, ACDF established proven surgical treatment for degenerative as well as traumatic spine. Fusion of the vertebra done to provide the stability of the spinal column. Use of graft and cage helps in relieving buckling and posterior longitudinal ligament buckling of PLL and ligament of flavum. It relieves the cord compression and restores the neural foramina volume. Tricortical autograft is considered to be the gold standard, but some complications like graft collapse, graft extrusion and donor site, so the fixation of anterior plate system is advised. Newer surgical techniques to eliminate the donor side morbidity and graft related complications. Now it is titanium cage also provide the osteogenic potential and the strength system to the cortical strut. Cages rely on the principle of annular tensioning, restoring the disc height and volume and size of the neural foramina, which is indirectly. Cage immediate stability it will provide, minimize the donor side morbidity, easier implantation and procedure and less operative time. And some studies shows no correlation between the cage subsidence and the outcome of the patient. So we have one patient with a cage subsidence. Titanium, different type of materials can be used like PEK, carbon fiber titanium. There are studies which showing no difference in respect to the cage subsidence. Concluding, use of titanium cage filled with a cancellous bone is less invasive, simple procedure for ACDF. Use of tricortical graft with plate fixation for titanium cage shows adequate stability and reliable functional outcome. And titanium cages for the cervical fusion consider an efficient alternative to the tricortical autograft. References, and thank you.
Thank you. Just a quick comment from me. I think if you take tricortical graft,
yes, sir.
It's okay to use mallet and chisel, but it's much better to use an oscillating saw because the micro fractures can interfere with bone union. The other thing is that your topic is on comparing tricortical graft with plate versus cage.
Yes, sir.
But you told about neurological recovery in both cases. I mean, this has nothing to do with neurological recovery. Neurological recovery depends on the decompression,
yes,
not on the type of fusion. So I think you should not deviate from the main topic when you present something. Now, comments from the audience.
It's your third cortical surface. Where you put anterior or posterior?
Anterior, sir. Anterior discectomy.
Okay. It's a third cortical surface of your tricortical graft. You put anterior. That's what you're telling.
So
how is weight transmitted in the cervical spine? Because the cervical lordosis, weight is transmitted through the posterior aspect of the vertebral body.
Yes, sir.
So ideally, the third cortical surface should come posterior. But putting it anterior is more easy. Okay,
yes, sir.
good.
Yes, sir. So for titanium cages, after the 6 months, the interspinous, with the fusion, interspinous distance in flexion, it will be less than 2 millimeter after the fusions. And it is more than 2 millimeter, then we have flexion excess. Yes, sir.
Where you use hydroxyapatite crystals. Any difference in fusion rate any of you have experienced? Nowadays we use G-bone, hydroxyapatite granules rather than autogenous bone. Now, what is the fusion rate in both? Has anyone felt that this is inferior or equal?
No, I think you can mix both. Usually what I do is I take graft from the local bone itself, possibly drill out a few osteophytes and find some spongy bone and mix it with hydroxyapatite. I think that gives a better fusion, along with the cage, along with the peak cage or whatever, depending on the affordability of the patient.
Bone alone gives a better fusion, there is no doubt.
But then the problem is with the quality of bone which you get locally. Otherwise, you will have to put another incision and get for good quality bone. That again adds to the morbidity. So this is what I usually practice.
That you can do a stab incision using a curette. You can take the cancer.
But still, from iliac crest. Iliac crest still. Yeah, but again, sometimes it adds to the morbidity. The pain over there is much worse than he will be worse than what he was before.
Thank you. Thanks very much.
There was actually some one paste with the Medtronics guys. That used to give good fusion, but due to some licensing issues, I think they've stopped. Yeah. Paste mix it with hydroxyapatite. It used to give good fusion rates. It was around 6,000 or something those days. Yeah, there was some sort of a paste which was available earlier. It's not available anymore.
Our final presenter is Dr. Abdul Rahim Shan, consultant neurosurgeon.
Respected Chair, faculties and my dear colleagues, today I'll be presenting a rare case of giant invasive spinal schwannoma that presented to us and the surgical management that we took upon this case. It was a 76-year-old male presenting with progressive weakness of lower limb from the last 1 year, and this complaint worsened from the last 6 months. It is then that he consulted doctors, and by the time he was brought to us, he was chair-bound with urinary and fecal incontinence. Systemic and neurological examination, he was an obese patient with tone of lower limb was almost flaccid. Hip flexion was 3/5, knee flexion hardly 2/5, and angle, there was hardly toe movements. Sensation was decreased from L1 to S1. Perineal sensations was however preserved, but anal tone was lax. So this was the MRI that he had already taken. There was, as you can see, destruction of the vertebral bodies from L2, L3 and L4, especially the posterior elements on the left side, and the vertebral body of the left side was destroyed. Only a thin rim of body was intact on the right side. It was a diffusely contrast enhancing tumor. The good thing was that ureters, kidneys and the retroperitoneal organs were not involved. The vascular structures were also not involved. And you can also make out a thin rim of psoas muscle that was remaining intact without any retroperitoneal breach. Other than that, this was a tumor that was more toward the left side, and only a thin rim of bone was preserved on the right side. As you can make it on the CT, only very thin rim and a very thin pedicle was left up on the right side. The rest everything was destroyed by the tumor. So this was the coronal section. As you can see, from after L1 till L5, there is nothing other than the tumor that is holding the spinal column. And the L1 vertebra, again, that had some fractures in it. So we were very much anxious as to how to manage this particular case. USG guided core biopsy, the patient had already taken it from a tertiary care center already before coming to us, and it showed features of schwannoma with no features of malignant peripheral nerve sheath tumor. So we decided to go for surgery, but there were so many challenges that we were anticipating. One, the tumor removal itself. To what extent should we remove the tumor? This was a highly, very contrast enhancing tumor, so we were expecting the tumor to really bleed. And second point was that, as you can see, there was a thin psoas muscle that was covering the tumor, and whether we will go for retroperitoneal breach or whether we will be requiring any mesh plasty to prevent retroperitoneal herniation. These were all the doubts that we had. We also had our surgical oncology colleague in stand for us intraoperative help. Now the status of nerve roots. As you can see, the patient was not totally paraplegic. Some nerves were still functioning. The perineal sensations were intact. So after our surgery, what will be the condition of the neurological status? The problem was that we do not have neuromonitoring setup in our hospital. We do call from external support. For that 2 weeks, our external support system was not helping us because for the rest of the 2 weeks, the external neuromonitoring support was totally booked. So we have to go to the surgery without intraoperative neuromonitoring. Now the biggest challenge was that literally there was no vertebral body in the L2, L3, L4 once we remove the tumor. So what will we do to reconstruct it? We will go for a long construct. What about the stability? All these were in doubt. The first and foremost thing that we concluded was we will not be able to finish the surgery in 1 day. So we planned for a two-step approach or 2-day surgery. And we were really anxious and doubtful regarding the postoperative neurological as well as the general status of the patient. However, we went in for surgery. The first day we decided for tumor removal. We went for the L2, L3, L4 laminectomy. Especially on the right side, you can see this is the tumor on the left side. Once we did the subcutaneous dissection, the tumor came up open on the left side. We removed the lamina on the right side. So it was a moderately vascular tumor. Right after subcutaneous dissection itself, the tumor started to bleed. And we did an L1 laminectomy and we made the dura clear at the proximal level. And what we found was that this dura was entering into the tumor. So we were not able to delineate a plane between the tumor as well as the dura. We went lower down, did an S1 L5 S1 laminectomy, and we were able to see that the distal roots were splayed, again coming from the tumor. So we tried to trace these two ends. What we found was that the tumor was intrathecal in origin from multiple nerve roots. These roots were going into the tumor, and the distal roots, when we traced them proximally, what we found that some intact roots were displaced to the right lateralmost extent by this particular tumor, and the entire left side was the tumor was encroaching into the myofascial planes. So we removed the tumor as much as possible, especially from the lateral extent. We had our surgical oncology colleague helping us to remove the tumor. They are much more well versed in removing soft tissue sarcomas of that region. We removed the tumor of the spinal column, and we left the tumor that was covering the roots, intact roots, we left it unremoved. And this was the first day. So after tumor removal, adequate tumor removal, we packed the entire surgical area with big mops, and we did a stay closure. After stage 1, we planned to ventilate the patient for 24 hours till the next day. We had multiple transfusions to the patient intraoperatively. Now, things were not good with us on that day. Soon after the patient, once he was shifted to the post-anesthesia care, he had a cardiac arrest with desaturation. However, our anesthesia team was very prudent to resuscitate the patient then, and we started on inotropic support. Now, we were very doubtful or dilemmatous whether we should continue with the second stage the second day itself. The only good thing that we could we had at that day that we did not get any retroperitoneal or Sway's breach. So after a grand discussion with the bystanders and the anesthesia team, our decision was that we will take up the patient to the theater the next day. If hemodynamically he is stable, we will continue with the surgery. For our luck, we were able to wean off the supports at the early morning the next day, and we went in with surgery. So the biggest problem again we were going to face the second day was that the conventional rod system, the pedicle screw and the rod system will not be adequate in this particular condition. So we called up our implant support guys, and they come up with a novel idea called as duplex screws, where you do have two heads with a single screw, and in these two heads you can add a complementary rod system. So this was a new pedicle screw what they gave us, and they also proposed an expandable cage to be kept at the area where we do not have vertebral bodies. But again, the problem was the maximum extent what they could achieve with this expandable cage was 7 centimeter, but what we required was almost more than 9.5 to 10 centimeter was what we required. So our decision was to go with a fibula strut graft of 10 centimeter. So we had the duplex screw inserted at the D12 as well as the L1, L5 level, and normal pedicle screws at L1 and S1 level. And the normal rod system was inserted in this lateral part, and this is the duplex screw or the additional screw head what you have, and we did a complementary rod system we inserted in the medial part. And we gave the fibular strut graft was kept snugly fit, almost 10 centimeter fibular graft was kept in the area where you do not have the vertebral body. And this is the entire area we have where we have removed the tumor, and the normal roots are displaced to the lateralmost extent, where you have some vertebral body is remained. And this was the post-op X-ray where you can see the fibular strut graft remaining there with somewhat satisfactory construct what we were able to obtain. But challenges were not over. We ventilated the patient for 24 hours post-op, and we were able to wean off and extubate the patient. Post-operatively, one of the biggest relief was that we were able to retain the neurological status, and the angle started showing a mild improvement. Initially there was only toe movements, but here a slight flexion we were able to make out. But for 5 days post-surgery, the patient started to have multiple episodes of fever, and there was urinary tract infection. Even preoperatively, the patient was catheterized for a long period. Preoperatively, the patient did not have any signs of urinary tract infection, but post-operatively, definitely he developed urinary tract infection, and there was mild respiratory tract infection too. And to our again dismay, counts were elevated, and blood culture showed gram-negative bacilli, especially Klebsiella. Probably that should have been catheter central line associated. The patient was really obese. We were not able to get peripheral lines, so we were having the central line. But anyhow, 5th post-operative day, we removed it. We went for a jugular vein. However, we were able to discharge the patients 2 weeks post-op, but still we were very doubtful regarding the construct as well as the fibular graft. What will be the fate? Anyhow, post-operatively, 1 month we called up the patient, and it was to our relief that the construct as well as the fibular graft was in place. The patient had started improving his lower limb power, and he was able to sit without support. The wound has started healing. And histopathology showed features of schwannoma. There was no features of atypia or malignant peripheral nerve sheath tumors. So giant invasive spinal schwannoma, by definition, they are benign tumors that encompass more than 2 vertebral levels. They may erode the vertebral bodies, extend into extraspinal space and into different directions, and they also disrupt nearby myofascial planes. So most common seen in 30 to 60 year age group, but it could be found in any age groups with equal incidence in both men and women. And tumors, they do originate from Schwann cells. They are benign in nature. They most commonly arise from intradural extramedullary compartment, but often they are found very incidentally. So by the time you detect it, they might have already grown into a large size and destroyed many vertebral bodies. This is one of the classifications of benign nerve tumor proposed in Indian classification, where you have the type 5 classification have included this type of giant schwannomas with the destruction of vertebral bodies. These are some other review literature where they have reported such cases where they went for single as well as 2-stage approach. So a conclusion is that even though GIS or giant invasive spinal schwannoma is a rare benign tumor, they could be challenging. Managing these cases could be challenging because of its invasive nature as well as destructive nature. And special attention should be made regarding reconstruction of the vertebral body because it is custom made. Depending upon the patient, depending upon to what extent that this particular destruction has happened, we should customarily design the reconstructive techniques. And in this interdisciplinary approach should be always sought for whenever you need help. Like we had our surgical oncology colleagues to remove the lateral part of the tumor because they are more well versed and expertise in removing soft tissue sarcomas of that region. And we had a good help from our orthopedic friend also to get a good fibular graft without affecting the stability of knee as well as the ankle joint. Thank you.
Thank you. That was a very complex case. Just want to know, how did you close the dura? Did you have any difficulty in closing?
So we were not able to close the dura, sir.
So lucky there is no CSF leak.
Till now.
I have a question because you did a excellent work and it's a very difficult tumor, I agree. But I doubt, is there any need for fixation? One thing. Second thing, you could have avoided fixation if you had done a hemilaminectomy, preserving the posterior tension band as well as the other side lamina and structures. Because patient is already maybe sitting up, he is not able to walk at all.
No, sir.
So that doesn't mean that he has instability. That is eroded, but there are not instability there. Or you could have put a screw. After that, you could have put a long screws without that duplex thing.
So the already existing vertebral bodies, we tried to put a pedicle screw in that existing L2, L3, L4 vertebral bodies.
It is not possible.
It's not getting.
So you have to go above
and below, sir. So there was the L2, L3, L4 was area where there was nothing.
Yes, yes. I am telling that it's extremely difficult, I know, because 72-year-old patient on catheter, you have a sepsis, all the problems. Only thing, you could have avoided that second procedure, or you could have waited for some time. As if there is an instability, you can go a second go and do the fixation. It is my personal view.
I also want to pass it. Actually, I agree with Ajit. You know, what was the necessity for doing on the second day itself a stabilization procedure for a 76-year-old man with history of difficult to swallow 6 months, a 76-year-old man. More than that, he had cardiac arrest, resuscitation, on ventilator. Just because he is on ventilator, does it mean you have to finish stabilization surgery next day? I absolutely agree with Ajit. It was an overkill, but God was with you. Otherwise, you should have waited and done at a later sitting. Okay.
With this, we come to the end of a free paper session. Once again, thank you to our chairpersons. We will be commencing with our next session shortly.
This is a small procedural change, and as I have been responsible for writing up the bylaws, this is a violation of the bylaws, and therefore it has been assigned to me to violate the bylaws, and I make this announcement.
as our incoming president, Thomas Ibe, has to leave a little early. He cannot be here for the official handover ceremony during the valedictory function. And therefore, he has requested some help in this regard, and we have decided to help him out by preponing the handover ceremony, the official handover ceremony, just now before the presidential oration. But it is just an official handover, but the president shall continue his presidency till the valedictory function is over. At least till the oration is over. Rules are rules. They are made to be broken, and we are breaking the rules. Thank you.
I invite Dr. Jacob Alapat to formally hand over the plaque.
Respected senior members, Sri Umar sir, Iqbal sir, Mohanlal sir, all the other senior members, there was some logistical issues. I didn't really know that it will be in the last part of the session, and I have to leave. I'm very sorry that I have to leave by Janashatabdi. Anyway, the other thing is, what I found was a very good registration, especially the young people coming in large numbers to NSI. Kerala chapter is a very, very good sign. And the other thing is, there is a need to have an interaction between the neurologist and the neurosurgeon. There are many areas, for example, even the decompressive craniectomy after stroke. Many places where we have to have close liaison, and so that the patient is benefited the maximum. There are many instances where the neurologist is not happy, the neurosurgeon is not happy at the final decision. So more interaction and more collaboration will result in the optimum treatment for the patients in many situations, not only in stroke, but in many situations. I think there's a big scope, there's a big gap which has to be bridged, and the Kerala chapter of NSI, the Kairali Neurosciences Society is ideally placed to bridge this gap. I thank all the members for giving me this opportunity. I'll try my level best to coordinate all the activities of the society. Thank you very much.
We will be commencing with our first session. To formally chair this session, I invite Dr. Salam and Professor P.K. Balakrishnan. We will now be having our presidential oration by Professor Jacob Alapat. To introduce him, I invite Professor Raymond Morris onto the stage.
Morning everybody. It's my pleasure and privilege to introduce before this august audience the eminent neurosurgeon Dr. Jacob Alapat, our outgoing president of the Kairali
Neurosciences Society. He is the eldest son of Dr. K.A. Paul and Rani Paul, and was born on May 22nd, 1960. He had his schooling, early schooling, at St. Paul's Convent School at Kurichira, Trichur, and later he left for Don Bosco High School at Irnalakuda. He did his pre-degree from St. Thomas College, Trichur, and joined Kottayam Medical College for his MBBS. He did his post-graduation in general surgery from Kottayam Medical College and obtained his MCH degree from Trivandrum Medical College. During this period, he has also obtained the fellowship from the Royal College of Surgeons, UK. He has also a covetable academic career, a professional career. He joined as a lecturer in neurosurgery in January 1987 at Kottayam Medical College. And he retired from the government service, not retired, he actually took a voluntary retirement from the government service in 2013 from Calicut Medical College. During this tenure, most of the time he was working at Calicut Medical College. He worked there as a lecturer, assistant professor, associate professor, and professor and head of the department of neurosurgery there. And actually he molded that department and made it one of the best departments in Kerala during his tenure. And during this short period, he was also posted as professor and head of the department of neurosurgery at Calicut Trichur Medical College from January 2004 to April 2005. And he had also worked as a consultant at Kaula Hospital under the Ministry of Health at Muscat from 92 to 97. So from the year 2087, he has started his career as a neurosurgeon, which he is still continuing as the consultant and senior consultant and head of the Department of Neurosciences at Astor NIMS at Calicut. He has trained many neurosurgeons who are working at various capacities in all over the world. He was the examiner for MCH at various universities in India. As a member of many of the faculties, medical faculties in many of the universities, he has been able to bring about many changes in the curriculum of neurosurgical teaching. He has written many chapters in many of the textbooks. He has to his credit many publications in the national and international journals. And he had a stint for research work, and he has a lot of publications in this research field also. And while I was going through all his research materials or papers and all those things, it comes up to so many foolscap papers, not even only the titles, they come up to so many foolscap papers, which I cannot present all of them here. So he was a bright teacher. He was an academician who was working for the students as well as for his patients. He was a meticulous surgeon of par excellence, a cheerful and empathetic doctor. All these qualities he has imbibed to his next generation. And he was magnanimous enough to take a VRS at an early age and came out of the government service at 2013 when he could have stayed there for a few more years and handed over the department to his juniors who were capable of carrying on those work, and they have been doing that work very well till date. At present, he is the senior consultant and the head of the Department of Neurosciences at Aston NIMS at Calicut. He is married to Mrs. Sujata Jacob and he is blessed with 3 sons. His eldest son, Dr. Paul, is a neurologist who was trained at Sri Chitrathirunal Trivandrum and at present is working as neurologist at Aston NIMS Calicut. His second son, Dr. John, is an oncosurgeon and is working at MHR Cancer Institute. His third son had a brilliant academic career. He passed out as an engineer, but he is at present taking care of his family business. He is a person with cheerful attitudes and deep attachment to one and all of you, as you may have all realized during these years. The Kairali Neurosciences Society wishes Dr. Jacob a very happy, fruitful, professional and personal life in the coming many years. May the good God bless you and your family throughout the coming years. Thank you. Thank you so much.
Professor Jacob, please come to the dais.
Actually, sitting there, hearing all what Raymond said, thanks Raymond, I was reminded of Varma Sir's statement. Varma Sir is our senior pediatric surgeon, who was former principal of Calicut Medical College. Sir said there are 2 instances. Sir said that time there are only 2 instances when people praise you and say good about you. One is during your send-off, where you get a chance to reply back. Second is after your death, where you never get a chance to hear or reply back. This is the 3rd instance. I think Varma Sir has not remembered this. 3rd instance when you hear, when you have an oration or something like that, people will speak only good things about you. So thanks for the good words spoken. I think ever since I took this post of this president, this oration was disturbing me, and what to speak on this was always a problem. So yesterday when Suresh said, what are you speaking subject? Are you speaking philosophy? It is, let us see what we are going to speak. Where is the marker? Okay. Just sit down and relax. Enjoy the speech. Very boring. Shut your eyes and take a nap. I showed 2 slides. One is I wished all a happy new year, and I showed a clipping from the World Football Music. All this was intendedly shown because before 23, 2 years were really bad 2-3 years for us. COVID taking a lot of lives of our relatives, friends, doctors, nurses. COVID taking off the pleasure of life. We cannot go out. We were entrapped inside our houses. There was no
contact for our kids, lot of problems in family life, personal life, and in kids' life, and whatnot. We forgot all that. 23, we celebrated the Christmas, we celebrated the New Year. Sorry, Paridosh, when I say a bit of Malayalam, we really celebrating the freedom, the social freedom we got out of this COVID disease and the restrictions they had imposed. The World Cup football, but COVID was a big leveler, you should remember. COVID was a big leveler, from the big to the small, to the rich to the poor, all were affected and all were put in the same platform. You should remember that. We should not forget that. Second is this football. Football is a very, very popular game. No one thought that Qatar could host it. And you should remember that it was a fantastic, well done football World Cup. Best than many, but the wide European countries, American countries, all of them thought. And who came to the semi-final? A country like Morocco. So there was a lot of things that happened. So diseases is football or sports are levelers in our life. Levelers, not what we think. They are the two things that make you same on the same platform. Another thing from Qatar football I want to say, this it struck my mind so much that after the first match or something, there were a few people collecting waste and garbage from the stadium. We know that were from people all from Japan. One thing that was common, they were all from Japan. Just think, and we had the fortune, I think Sri Lanka also had the fortune to see, we should see the discipline that was enforced in that country and the smooth conduct of that. When 1 lakh people get out of the stadium and enter into, there is no rush, no problem. So all this really fascinated me. So I thought, I am wishing one day our country also will be a country of such discipline and such order. Why I labeled my talk as avial is because it contains a lot of things. Avial is a very common dish we Malayalis eat. Again for Paridosh, it contains a lot of avial ne kashnam murichu tharam paranjal pachakari kadayil thinനാൽ we will get lot of such things, but that differs. If you get the best products, only you will get the best. So everything may not be as good as in this avial as you eat. So this I told already but I am still repeating because actually the incoming president also told the same aspect, that the neurology, it's not because of running in 2 sessions. That interaction between the 2 specialties of neurosciences, between neurology and neuroscience is so critical. Take stroke. So if a patient with a large vessel occlusion comes, they attempt thrombectomy, they attempt thrombolysis, all these well good. And when the patient goes down in GCS, you give the call to the neurosurgeon. On the other hand, when the patient comes itself, a call is given to the neurosurgeon or neurosurgeon resident, and he is informed, he is well aware of the thing. And we know the results are much better when we operate this patient a step ahead before the pupil is dilated, step ahead before the GCS code drops down. So I wish, how can we be separated? That was my first title. So when you see stroke management, it is actually that mental attitude between. So how can we be separated in stroke? Then how can we be separated in epilepsy? Epilepsy is a field, I think, you know, neurologist, you think you do, but the neurosurgeon also has to be involved. So the pre-op meeting, the counseling meeting, the patient interaction, the patient relatives interaction, the neurologist and neurosurgeon should be integral part, and then there will be key successes. Then there will be, I can 100% vouch, then there will be key. You should not talk separately. Movement disorder, DBS, you all know. But it is not that person alone and that person alone. It is, I am telling, as a whole fraternity of ours. When we react, in varies from hospital to hospital, setup to setup, I do agree. Then fourth is neurocritical care. Neurocritical care is a very important field, because if you speak, because these patients are more sick, If you speak one language and the other neurologist speaks another language, it is going to be more trouble for the bystanders and relatives. So speak together, convey together, and communicate together. Vascular intervention. So in the hospital where I work now, the radiologist, the neurologist, and neurosurgeon work together in the neurocath lab. And that makes a lot of difference. And actually it is for very silly reasons. Many a time, some neurosurgeon in the past has had bullying character, did something to the radiologist. So the whole spite of radiologist goes for a different stake. And this has to be changed. And I am personal, this is quite personal for me, because I think the neurologist should stick with their stroke and the neurosurgeon with aneurysm and such things. There can be some overlap, and the radiologist complementary to each other, because you cannot separate clinical medicine and intervention in two ways. It has to be as one part. Neuro rehab is the new thing coming. Again, in neuro rehab, unless you know what is his previous neurological status, his basic pathology and pathophysiology of the disease, how can we do good neuro rehab? So this is the first point I want to say. Next. This is how can we be proud. This again I shared in the same thing. There is a quote from Malabar Neurocon. This is a Malayalam poem for Veridosh. This is only what he is telling. In this big world of the planet or the galaxy, we as a neurosurgeon or neurologist, this is a small speck in this world. We have nothing to be proud of. But we as a community is the worst. We think so much of it. Most of you might have seen this British clipping.
Still, I managed it. I mean, parking is not exactly brain surgery, is it? And I should know.
Why is that? You're a doctor.
Careful, I'm a doctor. I'm a brain surgeon. Big difference. Big difference.
So this attitude should change. We think we are only another doctor group doing our job. Cardiothoracic is important, peripheral vascular is important, lung surgery is important, gastro is important, and you should have that humility from your heart and mind, and when you behave also you should think. You can have your ego, which is good, but we should not be proud. Third aspect is what I want to say is, how can we ignore our health? This is a very important aspect. However I stress, I feel this will not be enough. See, most of the time one goes for MBBS, MD, MS, DM, 30, 31, 32, 33 is the age when one is finished through. And then when he starts as a junior surgeon, by the age 40 he learns some work. And by that time, if you are not looking after your health, you had an MI, you had a stent, you had some form of disability, which will be a devastating effect. So please take care of your physical health. Physical health definitely includes your mental health. Why? How can we mentally be happy? Mentally be happy, be relaxed, have hobbies that I am coming to, and definitely your fallback should be on your family for a good, peaceful, stressless and peaceful life. Most of the time what happens is we take all our stress in the hospital and bring it back home and then share it in the family and make their life also miserable. This is all part of which I have undergone in my life. I may not have been perfect in that, but still, if the younger generation can understand that and take, now there are plenty of neurologists and neurosurgeons. It's not one neurosurgeon in the whole world. You need not work alone. You can have teamwork, 2, 3, plenty, and don't think your assistant is your competitor. You always, most of the time, you suspect and always think you are the great senior neurosurgeon. Take your juniors into confidence and make your life stress-free. what I was, don't forget to live your life. Develop Don't forget to live your life. Develop a hobby outside the work. Keep your work close, but your family closer. This is again a slide I want to show. So, this is moving fast. Please come help me round. Okay. So, most of the time, see this. So that is a graph showing. See, you most of the time it's not possible. We peak between the age of 50 to 60, nothing great in that. So once you peak after 50, you should accept. After 60, you have to slow down. You have to come down. Still, you keep on certain people. Maybe I myself also is in that group. Keep on hanging, not letting anything. You have to age and age gracefully. That's very, very critical. And if you don't peak by the age of 50 or 60, that's also a problem. Here you have to say 3 points. One is, see, everybody can grow as after your PG, post-graduation. You can be active in your local town. You can be very actively operating. Publish some papers, do some good academic presentation, organize some conference. That is one level. The second level is you are in a teaching institution, you are a better person, you have some small clinical research work, done everything, and you are known in the state or in South India level, or third level is a bigger level. Everybody cannot achieve all these. That is an international figure. You become a highly motivated surgeon, you are very much known all over the world, you have got international publications, but most of the time you should remember, you should understand yourself, your limitations, and aim what level you want to keep. Level 1, 2, 3. See, if you are happy in one level, be there, level 2. And striving for achieving to the level 3 may not be practical in the available circumstances. So do accordingly and be happy with these levels of your career. And pace your career properly. If you do not pace your career and if you try to jump, you will only be more unhappy and more distressed and producing no peace in your mind. So, what I have done is, I have been working for the last 25 years in this city of Calicut, Wayanad, this area, Malappuram, 25 years. 15 years I was in government sector, Calicut, almost 1 year as Raymond said, went to Trichy, and then another 10 years, last 10 years I'm in MIMS Hospital, a private setup, and I will just share what experience I have in each field of neurosurgery, shortly and briefly, because if I am shooting time off, tell me to stop, because that's okay. Oration is nothing great about it. In 1997-98, I came to Calicut Medical College. When I was, that I will say, so from there to 2023, 25 years I have been in this. This gentleman, everybody knows, Sanal Kumar sir, was a strong source of encouragement, and it is with his first man's support that I started working in different areas of neurosurgery. This is the second man on the Premraj Mohan, whom we actually honored yesterday, and very silent man, unsung hero, who was also a source of inspiration and work for me, with whom also I worked after. After that, I mean, when I speak of Sir, to me, he's just like the only man whose hands and mind is free and fully committed to patients. Actually, when the neuroendoscope workshop was being conducted in Calicut Medical, all these people, KL, Siva, Premraj Mohan sir, and myself further, these two, this is Chandran sir, he has passed away, and Shankaran, the former, he has also passed away. So when the workshop was being read, almost same people were there, plus Rajiv and Ashalada in that inaugural function, KL. So first lessons learned during this period regarding spine surgery. See, because we were loaded with cranial cases, lack of anesthesia time, we could not attend to much of spine. But from 98 to 2001, 2000, early we did do. But the basic principles in spine surgery are just, when there is a compression, decompress. When there is an instability, stabilize. And when there is an alignment loss, align. This is the basic cardinal principles on which spine surgery works. So whether it is craniovertebral junction, C1, C2, what Goel says, there is an instability, that's the reason why you have got Chiari. There is a listhesis on the other end, there is also an instability, so we have to fix. So fixation is the key in spine surgery, and we as a group have not learned fixation as to the level of orthopedic, but that was a very good initiative from the Trichy Medical College doing scoliosis. That will spread, I am sure that will spread in the neurosurgery circles more and more, because that is a government setup, free done, more cases will be done, more screws will be put by the neurosurgeons, and more experience will come. So these three principles always remember, and this alignment is the one which we are not doing well, because especially scoliosis we are not doing much, and which we will have to come back to. Motor neuron disease is a disease because whenever you do spine more, remember you will have some problems here and there. Spine is a more trickier decision-making surgery than cranial surgery. We all know that. I'll share the story of a doctor's husband who had a spinal foot drop and a disc demonstrated. He went from this side of Kerala to the other side of Kerala, got operated outside the state, and finally to realize after some time this her husband had motor neuron disease and is going down day by day, and nothing happened because the surgery did not actually worsen the motor neuron disease. Actually, if you think it that way, if you had the benefit, should have improved if it was a compressive disease. But we should be on the lookout not to operate on such cases. So that is the importance. Again, combined work, always refer to neurologists, do NCV, EMG, and this lumbar quadrant, that is the story, lumbar quadrant disc syndrome, the issue is, when you operate after developing, especially L5S1 disc, they improve, but most of the time this intermittent catheterization also, it is better prevented. It is as emergency as an extradural hemorrhage. Their lifetime is, in fact, the litigation case against Salkwar sir is one such that. So always remember, if you are having a patient with an impending, you should force them for one of the surgical procedures, whether it is minimally invasive, whether it is endoscopic, whether it is fenestration, whether it is tube, whatever you are doing, you should be pushed in for surgery, especially L5S1. And this IDM meningioma, one thing, my observation is that IDM meningiomas in spinal, when you follow up for a long time, will tend to recur, because we cannot do a Simpson's grade 1 excision, especially in anteriorly placed meningioma, especially in young patients. If you follow for 20 years, you will get the recurrence. If you follow for 25 years, you will get the recurrence. As I already said, case selection is important. Patient will not come back to the he will come back once to you, then he will go to another person, especially in private setup. In government setup, spine OPD, he will come back to you, he will go. Oh, the only good thing is the consultant who is sitting there changes, so you need not face him every time. But in private setup, you are the same person facing, so he will not come back to you every time he has a failback. So very careful. If you are working in the same place for 25 years and if you have got a 1 or 2 failback every month, you can think how many failback will be there and such a bad name you will have. So very careful about spine selection. And one should earn his surgery because there is more than, as we know, more than important psychology. This ACDF posterior approach, ACDF to me is the best when patient has something where we have got a subligament disc, sequestrated disc, best results. We know that. Whenever it is something more degenerative and we are going posterior, the results are not very encouraging. Laminectomy and lateral mass fusion. So there also your communication will help, and what the patient and consultant has to expect in between has to be very clear. Acoustic is an area we traveled a lot. The philosophy of acoustic surgery has changed. Suresh Nair sitting here will say, in those days the aim was to remove it totally. Even if patient has got tracheostomy, Ryle's tube, that was the philosophy. Patient will be ventilated post-op, then every day patient will, you remember the days when Bhattacharya sir was operating. The anesthesia was not good, anesthesia medicines were not good, and anesthetist itself was not that committed to neuroanesthesia. So a lot of such issues. So acoustic surgery philosophy now has become preservation and functional preservation. Even if you leave a big chunk of tumor, which is not ideal, your facial nerve preservation is very, the two critical areas are CUSA and intra-op nerve monitoring. The more number you do, you will excel in that. Because intra-op nerve monitoring itself you should do, and your neurophysiologist should be very good. You should interact with him like one-to-one. He will tell you, stop. Then you can, like that you should do. And allow your assistant or somebody to, because acoustic surgery requires a lot of physical health and fitness. You cannot keep doing the acoustic at the age of 60. So, and there is a stepwise learning. Somebody opens, somebody can do the main part, somebody can close. So, teamwork is very critical in neurosurgery and acoustic. You do from skin to skin will not happen. You do from skin to skin will not happen as you age. And age and health factor, monitoring with best step, must be doing it regularly. This gamma knife is a problem. And this, you remember, radiology was less available. Patients came with large acoustics. Now we don't see such large acoustics. I remember a patient, the story was this patient had an acoustic. We suggested surgery. This woman never agreed for surgery. She was fine because she had only smile facial and hearing loss. Then she presented CSF rhinopharyngite ENT department. Then the ENT people referred it for repair to us. Then when I saw her, I asked, 4 or 5 years that I had senior 3-4 years. She said, that is not my problem. My problem is only CSF rhinorrhea. So she wanted the repair. But we repaired it, and the CSF rhinorrhea disappeared. But not often. That's why I said that sometimes in certain raised ICP problems, you repair the raised ICP problem, the CSF leak may reappear and you may have to do a repair later. Correct the anatomical defect that has happened. Aneurysm surgery is again one thing we traveled a lot in neurosurgery. I should say, if the junior most person in the department can clip aneurysm independently, that indicates the standard of the department. So that is what we were aiming at in MCH Calicut, and this is, I know it's slowly disappearing and coiling is come, but even it's relevant in government setup. In fact, Calicut Medical College is one setup where it may be still being clipped. For poor patients, it's good. It's not that discriminating. Don't think he's poor, he's poor, because it is less invasive. That's the way you can say. But it is still a very good surgery. Why? Because there's great learning in it. Because splitting sylvian, handling vessel, these steps are all useful. That learning is no more happening for the junior neurosurgeons when this aneurysm surgery is given. That is my only worry in that. But people like Janet, who is doing anastomosis, that is a very good thing we have to pick up. we should, that is what I was telling Rajiv, and our next workshop should be in anastomosis of vessels in the brain or in the lab in the anatomy. So aneurysm surgery, we can tell a lot about this, but I think we should move on. Very interesting, because aneurysm is an emergency surgical clipping. Patients will accept, we cannot shift the patient. We had a big number of series we had done. Actually, most of the time, that time patients were moving out of the state for doing, then we could step, and it is spread. Aneurysm surgery was being done right and left. Now the thing to be spread in all our government and private setup is we should train ourselves in endovascular. Pituitary is again an area we traveled a lot. Pituitary, what happened is that pituitary, we started from speculum through the mouth, oral cavity, then through the nerves. Now it has become clearly endoscopic, and it's better to have the ENT surgeon. That's what I feel as the workshop people are also telling. They take care of the nose. There's good paper from Rajshekhar and team, because his wife is also ENT surgeon. They have quality of nose after the pituitary surgery, and because you attend a workshop, you should be very careful in pituitary. You should assess quite a number of cases and only then slowly attempt it. And this always attempt non-functional cases first. The functional cases like acromegaly, Cushing's. Acromegaly is very difficult. I still remember when for one of the AIMS microneurosurgery workup, the professor of neurosurgery then was said, I will finish it off fast, and he went into the case and he could not finish the case. He could not finish the case, and he backed out without completing the surgery because it was full of turbinates, hypertrophy, mucosa, and bleeding all over. And that can all happen in acromegaly, especially if you don't have good ENT surgeon with you. You may lose the way. Cushing's, again, a difficult problem. Only if you have done enough Cushing's, you will know how difficult to declare cure in acromegaly, Cushing's. Prolactinoma now is most of the time managed medically, but there are issues. So always have endocrinologists as part of the team. The critical factor in pituitary and all these brain tumors is this single thing, consistency of if the lesion is soft, you can take it out. About meningioma, these are the difficult meningiomas. Whenever you start in your career, try with lesser convexity, simple meningiomas. But these clinoidal petroglyphs, these are all still totally removable. It's still difficult for us. We should understand, we should have a lot of teamwork in these, attempting these lesions. One thing about tendoral meningiomas, one thing I observed is that tendoral, because it has got two leaves, when we operate the supratendoral compartment, we sometimes get recurrence in the infratendoral compartment. If you work in the same place for 20 years, you will see such recurrences. Cases operated by your seniors for 10 years, 15 years back, coming with a recurrence in the compartment because it is coming from the other layer. This anterior foramen magnum, about all these we can tell something, but I think we should move on. This glioma is very interesting because we have all predetermined destiny, I feel. Immunology and genetics has thrown some light, not fully still. Brainstem glioma still our failure. Optic pathway glioma still our failure. About trauma, I have to say a few things. Trauma is still our bread and butter. We have a slight license in the management of trauma because but the way you manage a patient with trauma tests your comprehensive knowledge in neurology and neurosurgery. I have no doubt on that, from head to foot, and always involve the general surgeon, orthopedic surgeon. But this, to know what they are telling is right or wrong, you should have a basic knowledge, and you should be examining the patient. So this post-traumatic, and this is what I wanted to say, post-traumatic and post-operative meningitis is always a different cup of tea. Their behavior is different. A post-operative meningitis will present you with anything but anything. You will miss it if you are not on the lookout. Meningitis is something which you can miss at any stage of your career and life. Craniopharyngioma, still toughest of tumors in brains in neurosurgery, according to me. Tight, and TNTS is coming. We are not used to doing with TNTS in craniopharyngioma, but I think a few people in Chitra
Prakash and all is fully going for TNTS, and that will be the method of choice with good repairs to prevent CS leaf. So I think craniopharyngiomas are till the failure, partly failure, not much as brainstem glioma or our optic pathway glioma, but still there's high tendency for recurrence, and all this behavior is not in our hands. However you measure, the tumor biology is the most critical factor in the predicting the recurrence and behavior of these lesions. I just put this slide because I feel this is the most important slide to me. From this, all these people, Suresh, Sugadan, Anil, Baiju, Raju Paul, Praveen, Prem Kumar, Ramesh, Rajiv, Prem Kumar, Radhakrishnan, Tarun Krishna, Vijayan, Sri Kumar, Pavitran, Abdul Jalil, Rajesh Nair, Anup Narendran, Mahesh Bhatt, Ranjit, Unnikishan, Vineet, Jim, up to 13, I left. I don't claim anything. I don't want to claim anything. To me, they are part of my life. But the next group also after that I still acquired when I go for a Tuesday neuroradiology discussion to MCH Calicut even today. So Tuesdays are the days I look for, and from 8 to 9 I spend time and know who is there, at least know their faces and ask them some questions, and that is fine. It is very interesting that the Girija Madam and James sir, Girija Madam was my teacher in Kottayam Medical College when I was a third year student, and James is my 1 year junior and was the colleagues in neurology, and they used to send their posts in Somanath, John, Madhukar, Manoj, Rafiq, Rahman, Raj, Arun, Mustafa, Ghafoor. Saif was the one who helped us to do video EEG and start epilepsy surgery program in college. Baiju, Jidendran, Divya, Srijit. 2013, Rashid, Smita, from there I have left. I do not have much interaction with them. This name came to me because they are working with me. They did their MCH in some other institute. There are a lot of such graduates in different fields. One is Rajesh Nair, who did it in Chitra, Ram Narayanan in Nimans, Manish in Nimans, Jagat in Nimans, Sarida in Nimans. So these were surgery PGs who were motivated or maybe influenced by the neurosurgical posting they had. And in fact, I can definitely say Rajesh, Jagat and Manish were influenced. Manish, when he got his admission for MCH, he came to my room and offered me chocolate. Then I asked him, "What? No, sir, I have taken up neurosurgery, seeing you in my life." Then I said, "It was not very wise of you to do that." This photo is not very clear, but this shows the existing department in MCH Calicut. This is Rajiv, Pavitran. These names I told already, and the PGs then that time. And that's great. This was when they came for inspection. This gentleman is now the Vice Chancellor of the Medical University. He came for inspection that time to approve or increase the seats for MCH. I am not sure on that. This is the team for the last 10 years for me in MIMS. Some people have changed side, but still they are part in my team itself. Actually, I'll tell more about it. Murali, you can see, Srikumar, Naufal. All these people are there. Srividya, Last 10 years in MIMS was only an extension for me from college. I started on epilepsy surgery. I wanted to start endovascular very much, and we did have an interaction for DBS also with one team in Bangalore. But I knew there are a lot of limitations, and I'm sure it is going to happen in college. In government setup, everything will take its sweet time. However you push and try for it. So that is what happened. And here we have epilepsy surgery is well established. Murali Krishnan, Devish Khan, and Sachin's name also I put because he's the man who started it first. Movement disorder, Jim, Sujit, Olet, and we should have reached almost 100 cases in epilepsy surgery. Not a big number, we have to go a long way, but still doing service in the northern, all these in northern part of Kerala we start. Endovascular doing a good job, I believe. Naufal, Rafiq and Paul, Spine, Jim, Pramod, then he's a scoliosis, neurocritical care. I wish our neurosurgeons is an aspect. We have to take our own calls for our neurocritical care. Otherwise, after 10 years, we will say, ENT surgeon cheedu. We will say this, that fellow did. We are not doing the homework at the time when we should do. And after 10 years, making a hue and cry will not serve any purpose. Because a lot of people have already entered neurocritical care, and already only one person in CMC Vellore had done it. He did it because of other reasons, but whatever it is, that is served the purpose there. So in every institution, because the neurosurgeons are increasing in number, we should go in if he has a taste for it. If he has no inclination, please don't do it. This is the postgraduate, started in 2017. Rajesh, Ronak, Mithun, and this Karthik, the new joinee for. We have only one seat there, and that is all what's possible in that setup. My photo of childhood. That photo is 64 years old. Then my Holy Communion photo, and then my 3 kids when they were young. This is a photo when I was a 7th standard student. The teacher sitting near me, CA Mary teacher, she has taught my wife in Sacred Heart School. She's an ardent teacher. She instilled discipline in my life. She was asking me to tell the farewell speech because that school had schooling only up to 7th standard. That's a mixed school. After 7th standard, the boys have to go. So after 7th standard, sorry for boring you with this part of the history. I am not keen to talk on it, but still I think it's something had to be said. Because Nanadas last time told something, so I also thought I'll say something. That's all. This is Don Bosco High School, 8th, 9th, 10th, best school. That is where my character was formed. That was where I studied table tennis, basketball, baseball, any game you name. That was where, this was a school drama. C.L. Thomas, there is a popular C.L. Thomas, all teachers and students played together. And we were very active. And all this, I still want to say, we will have a person, a priest or a brother who will be with you at 8, 9, 10 years. And he told me at the end of the 10th class, you write what autograph. He wrote a note on me for the many things are best unsaid, Jacob. Leave them unsaid. That was an advice he said to me. He studied me. Even today, that is my problem. I overspeak. And many years later, Prem Raj Mohan sir once
while we were taking rounds, told me by the side. I was quarreling with some, I was young, with some patient at the time of discharge on some matter. Private Advan sir പറഞ്ഞ വാക്ക് ഞാൻ ഇപ്പോഴും ഓർമ്മ സാർ അവസാനം വരെ എല്ലാം ചെയ്ത് ഞാൻ കലവടയ്ക്കണ്ട കേട്ടോ. So that's all very key words. Why I am sharing it with you all, this all happens in all our lives. So this is Don Bosco School, Irinalakuda. I will definitely, the principal there, the sister, the fathers there, brothers there, all are great. This photo I'll spend some time. If you don't, I will exceed 5 or 10 minutes. Can you show? See, this is Medical College Kottayam. Medical College Kottayam. This is C.A. Rajan sir. This is Jayakumar sir. Kuryakos sir. Joseph sir. Many senior teachers will know. K.P. John sir. Radhakrishnan sir is no more. He is principal of NYC. Then Govidan sir, ophthalmology. Bhaskar sir. Balendra sir, urology. K.P. Bado sir. Theo Bado sir, surgery. S.A. Guru. Sir. John sir. Fantastic author teacher. Still remember him teaching. Dayantamavu sir. P.J. Ramakrishnan sir. Vaidyanathan sir. Chappanan sir. Marakan sir. Sudharan pathology sir. Madan Mohan pediatric surgeon. This one is not clear. This is Dr. Saib, son's father. Dr. Saib is left. I think he is left. This is Tangappan sir scheme. This is D.V. Nair sir, former professor of cardiology. This sir's wife, Sulojana madam, Sharda madam, Gainek, Mary Jones, Ram Jacob sir's wife, Lily madam, favorite teacher, Sharda Guru madam, Sundari madam, Madhav Kutti sir, Matthew Varghese sir, eminent figure. Took up surgery because of you. This is Tom Senso's wife, Elizabeth madam. This is Susan madam, physiology professor. So these are the teachers, and you can see this figure here. See, Dominic, my classmate. I forgot to say Kurian. Kurian's photo I was looking for. Kurian is actually a Don Bosco alumni, 1 year or 2 years junior to. Kurian was a member of the football team which won the state, international, national university winners. N.I. Kurian. That was a different Kurian. So I thought it is him because 2 years, he was 2 years junior to me. Kuriachan, 2 years junior to me. Hello, Kurian. No, that is after we left the school. That is why. This is MBBS school hostel photographs. Cycle tour. This is Vijayan sir. You remember football or basketball team? Vijayan sir of surgery. Do you anyone know? Nobody knows. This is my journey to Trivandrum. Back done first. So I joined this tutor, as he said, with J. Ran sir. Jayakumar sir was there, Iqbal sir was there, Raymond sir, and Pushkala. Then Tajuddin's photo I could not get. Tajuddin is in Bahrain. Then after working for, because that time I was doing my second year MS, I got, that time you can join as tutor and work together with some small paltry salary. And then when I got selection for MCH, moved to Trivandrum. These are the three people who, sir is no more. I don't want to say more about. Sir is bedridden and light. Went and met him last time. Taught not to speak on this. Sir silently teaches. Sulfi is there. Nalenpan is there. I will just tell two quotes from Sambashir sir to remember him. Anjanam എന്നത് എനിക്കറിയാം മഞ്ഞൾ പോലെ വെളുത്തിരിക്കും. എന്തിനാ മരത്തെ കയറണേ? പുല്ല് പറിക്കാൻ. പുല്ല് പറിക്കാൻ മരത്തേലാണോടാ കയറണേ, അതല്ല സാറേ ഞാൻ താഴോട്ട് വരണേ. ഇതൊക്കെ സാറിൻ്റെ സ്ഥിരം കൂട്ടാണ്. സാറിൻ്റെ ക്ലിനിക്കൽ ക്ലാസ്സൊക്കെ വളരെ നല്ലതാണ്. SK sir used to tell lot, teach, interact with us, and then we had such a good tough time, but looking back that was all good. Then I worked for 2 more years. Then there was no chance for you to get promotions because of some legal issues in the, so we had to, because of chance I went to Oman, and that was a place where I lived my life. 5 years, not much of neurosurgery work. I lived my life with my family, and that person whom I had showed was the anatomy professor in Sultan Qaboos. I went there for dissections, as Arun was telling, learned it and appeared for, because I was outdated with my MS, took my FRCS general surgery. Then Arun actually prompted me to go for FRCS. Then by that time I realized all this is waste. Then after 5 years leave, I came back. Then I joined MCH Trivandrum again. Only Pilla sir was that in that time. Monday to Saturday we operated and got our time. This is Tony. This is Uttam, Rajmohan, Shiva, Suresh, Anil, Ramesh Babu. All these were the best minds and best neurosurgical team we had that time. We used to operate, sit at 6 o'clock, 7 o'clock, have pre-op discussions, and then go home only late 8 to come back next day 8. This again, that time actually Anil P. Jacob was the junior PGs. This was a photo taken on another occasion. I just projected Jacob John's photo because all others I had put. Then I had a transfer to Trichy. In between, against my wish. I thought it was very bad, but I never thought it was the best part of my life. 1 year I spent life with my parents, with my house, and I realized my parents need me more. I never knew that there was a problem in my house. They were alone and all. So during those 1 year, I had 5 persons with me. All were professional tutors. This gentleman became a neurosurgeon. All of you know him. This gentleman became a neurosurgeon. This gentleman became a neurosurgeon. He's sitting there, Baiju. And this became a neuro rehab. This became a neuro anesthetist. 2003, I was there only few. 2004, midway I left. They are typical. You understood? No? We are the. This is what I said, with my parents, my house was in a dilapidated state. I never realized, when I stayed there 1 year, I realized that I need pay more attention than to neurosurgery, to my house and to my family. This is my father, still my role model. This is in between. I was not at all happy to leave medical college and go to, as Raymond said, to MIMS. I was not sure whether I will fit in. In my life, I had never dreamt that I would leave government sector, to be honest to myself. But certain circumstances made me, and I realized your adjustability is a sign of intelligence. You have to adjust with the newer, and I moved to, then when I moved, first trial options I tried in this place, because he was my student, so I knew whether I want to work and see, and there, these 3 people, Praveen later joined, and then these 3 the PGs, there are also PGs started, not officially under me. Team is important. See, this is what I want to say. OT team, ICU team, cleaner to sweeper, other departments, neuro anesthesia, Biju, Dr. Kishore, and the anesthetist in actually Ashraf's wife and all used to give us regular anesthesia in neurosurgery in college, neuroradiology, Rameshnan, Dr. Rafiq, then Rajendran, then Dr. Devarajan, neuropathology, Dr. Aparna, Salini, Lily, Dr. Kavita, neurophysiology. All these are ENT, Devi, Dr. Suma, all pituitary. So it was all team only that has helped me in this.
Why do you say all this? If somebody can take some cue or learning out of this, please, that is my only intention. From the mistakes that has happened in my life. What do you know? Going in time, this involves annihilating yourself. What do you know, you teach others and encourage others. What do you know, you teach? What do you know, you teach others, encourage others. Do not expect anything back. It takes some time to understand that last line. If I have any merit, it is getting along with individuals according to their ways and characters. At times it involves suppressing yourself. It is painful but necessary. To be a leader, you have got to lead human beings with affection. This is not my quote, J.R.D. Tata's quote. And this is the best quote I like, because that is a fact of life. This is my family. This is the latest edition, 4-5 days back. This person is my Thank you.
I would like to request Salam sir to please hand over the memento to Jacob sir.
I did not say anything about Salam. I have a lot to speak actually on, but he knows there is no need to speak it in a public place.
Thank you to our chairpersons. We will be having a short tea break for 10 minutes and we will be commencing again with our session at 11:45. Certificates for delegates can be obtained at the INTAS stall. Certificates for free paper and poster presentation will be available at the Torrent stall. Session. Before we proceed, I would like to announce that after our talks, we will be having a Kahoot online quiz for 20 minutes with attractive prizes being offered. So please stay for the same. We will be commencing with our next session. To act as chairpersons, I would like to invite Professor Girija and Dr. Jnanadas. And to introduce the recipient of Professor M. Sambashivan oration, that is Professor Iqbal, I invite Dr. Mohanlal.
So, with your permission. Good morning, everyone. For those of you who might not know, this society has 3 orations. One is the Cochin Neuro Society oration instituted by the CNS. The second is, not in that order though, Dr. Abdul Ghaffur Memorial Oration instituted by his son. And the third, Professor Sambashivan oration instituted by himself. He had donated 2 lakhs corpus for the conduct of this oration. When he was the first president of the society. At that time he had instituted it. Today, for this oration, the orator is none other than Professor Iqbal. He has a constant complaint that his name is the most misspelt name anywhere in the world. And these are the 3 commonly used spellings. The correct one you may guess. And I am so thankful to Professor Jacob Balappat for asking me to do this honor of introducing my close friend, Professor Iqbal. Who is standing there is Dr. Mehrnisa, who was the head of the Department of Anatomy and retired as the principal of Alleppey Medical College. And they have 2 children, 1 son and a daughter. Professor Iqbal has specifically requested to cut short the agony, for he is a very humble man who doesn't want to keep on listening to all the lies I am going to say, or perhaps he wants more time to annihilate you through his speech. So I am cutting short my presentation here of introduction. This is 1978. The team in Trivandrum Medical College with Professor Charles Drake. Soon after this, Dr. Jayagumar left, and in that shoe I stepped in. That was 79. So the team was 3, and then 1980, Dr. Iqbal joined there for his MCH program, first year. That time he was very active with his Shastra Sahitya Parishat, and Professor Sambashivan had warned him not to be so much active in the Parishat. But despite that, every day in our common room we see hundreds of inlands. Those days that was the communication. Hundreds of inland letters come, and he almost simultaneously with the left and right hand, he keeps on writing replies to it. And at the same time, he listens to our talk and comments also. So much so, we sometimes suspected he had a 3rd hemisphere as well. And while he keeps listening to us and he makes his comments, sometimes we try to taunt him. Being a staunch leftist, he has his own opinions, but however much we taunt him to draw him into a talk regarding any controversial subject in politics, he wouldn't be drawn in. He will just sit there with a smile. One thing we always were jealous about was his way with the fairer sex. He always befriends them much easier than most of us could do. So we were very jealous of him at that time. And he, having been a coronary survivor, he still chose to contest an election in which he probably reduced the previous margin of the sitting contestant. And unfortunately, he lost the election, but we lost a health minister as well. And this was 89, the team in Calicut Medical College. Professor Premraj Mohan is there on the left side. Dr. Sanal Kumar. Calicut. 89. A known speaker is a voracious reader as well. He has written, എന്നും എപ്പോഴും പുസ്തകങ്ങൾ കയ്യിലെടുക്കാനും അതിൻ്റെ മണം ആസ്വദിക്കാനും ഇഷ്ടപ്പെടുന്ന പഴയ തലമുറയിൽപ്പെട്ട ഒരാളാണ് ഞാൻ. ദിവസവും എന്തെങ്കിലും വായിച്ചില്ലെങ്കിൽ ആ ദിവസം പൂർണ്ണമായില്ല എന്നൊരു തോന്നൽ. അല്പം അസൂയയോടുകൂടിയാണെങ്കിലും ഞാൻ പറയാണ്, അദ്ദേഹത്തിന് ഈ പൊടിക്ക് അലർജിയില്ല, നോ ഡസ്റ്റ് അലർജി. ഞാനൊരു പുസ്തകം മണക്കുകയാണെങ്കിൽ അപ്പോൾ തുമ്മാൻ തുടങ്ങും, പുസ്തകം എടുത്ത് കളഞ്ഞിട്ട് ഞാൻ ഓടും. So he is a voracious reader. And currently he is holding these positions. He is the chairman of State Expert Committee on COVID-19 Management, joint convener, People's Health Movement, India, and President Mar Paulos Foundation. And the many important positions, a number of them, I'll just mention the significant ones. He was Vice Chancellor of the University of Kerala from 2000 to 2004. Soon after he retired as Professor and Head of Neurosurgery Medical College, Kottayam. He was also President of the Kerala Shastra Sahitya Parishad, and he has been member of the State Planning Board twice. He had worked in the medical education department starting as tutor in anatomy and then tutor in pathology. So he had already become a complete neurosurgeon after completing the knowing pathology and anatomy so well. And he retired from Kottayam Medical College as head of the department. So a voracious reader, a speaker, same time he has got quite a number of publications as well. These are some lists of publications. I am posting this in the WhatsApp group so you can read through it if you are interested. And there are a number of books in Malayalam as well, 25 books he has published. And needless to say, with all those achievements, he has innumerable number of awards to his credits. About 14 awards he has already got. An ardent student of Professor Sambashivan. I am very glad to introduce him and request him to do the honors of presenting the Professor Sambashivan oration.
Sir, please come to the... Yes. Seniors, respected seniors and my dear friends. Today, a very important day for neurological sciences, Oration Day. And this day is, for as far as I am concerned, it is one of the happiest day in my life, because Professor Sambashivan oration, Sambashivan sir was my teacher at Malabar Medical College, and also the orator, Iqbal sir also my teacher. So I benefited and learned many things from both of them, and learned many things from them. So I think that this is my Teacher's Day. I'm very happy to welcome Iqbal sir to the oration.
So I know Iqbal ever since I joined service in Kottayam Medical College, and later when I came to Calicut Medical College, also he was my colleague, and it is a pleasure to chair this session. And I know, and as already stated by the initial speaker, Dr. Mohanlal, he needs no introduction.
Good morning.
When Dr. Jacob Alapad informed me that I should give the Sambashivan oration this year, at first I felt very elated, excited, almost euphoric. But later I realized that it will be a very painful endeavor on my part to deliver Professor Sambashivan oration because of my very intimate relationship with him, almost emotional relationship with him. As we know that he has built up neurosurgery from its infancy, early infancy, against much odds, and made it into a discipline of youthful vigor. And also he has trained almost 3 to 4 generations of neurosurgeons, and I belong to one of them. But I actually joined for the neurosurgery MCH course only in 1980, but my relationship with him dates back to my third year student days, MBBS student days. At that time I had a very close friend. Still he is my close friend, even though he is no more. His name was Mulavana. And he came to me one day. I was staying in a lodge that he had a weakness of right upper limb. He was admitted in the medical department, and Dr. G.K. Warrior detected differential loss of sensation. You see, no other symptoms at all, signs at all. And the provisional diagnosis of syringomelia bar intramedullary tumor was made. Professor Sambashivan did a myelogram. Unfortunately, it turned out to be an intramedullary tumor. Professor Sambashivan operated on him. It was a malignant intramedullary tumor. It recurred. He was operated twice. He became later quadriplegic and died. And that was in 1968. From then onwards, I had a very emotional relationship with Professor Sambashivan. But apart from being trained under him, I remember him for another very important reason, because one of the traits in him, Dr. Sambashivan, about which we were all very uncomfortable, because he never will congratulate you or appreciate whatever good you do, either presenting a topic or doing a surgery. He will always point to the shortcomings in whatever you do. So we were very uncomfortable. So I had an opportunity after completion of my course. I still remember while he was standing alone in a neurosurgery conference held in Delhi, I asked him, "Sir, why is that you are not appreciating anything in us? Because we expect you to congratulate us, but you never congratulate anything, even when we do something good." So he made a statement which later actually imbibed me a philosophy of life. This is what he said at that time: a pat on the shoulder will keep you sleeping, whereas a kick on your buttocks will keep you running. Now, the spirit of this statement, I have made it into a 4D philosophy in my life. That is to say that what he was actually referring to was that we should have a dispassionate detachment in whatever responsibilities you do, but you should be always dedicated to your duties. In fact, because of the vagaries of nature, I happen to hold several positions in different fields, and because of this philosophy, I could somehow manage to discharge my duties fairly to my satisfaction. Well, now with these few words, let me pass on to the topic which I want to present here. In fact, I had a problem with titling this presentation. Dr. Mohanlal suggested something different, about which I will refer later. In fact, not only surgery, medical science in general as a whole is getting transformed last 30, 40 years at an amazing pace, and that is felt in the discipline of surgery as well. Now, when we talk about surgery, we will have to necessarily quote John Hunter, who very famously said, with a literary flavor, that the last part of surgery, that is operations, is a tacit acknowledgement of the insufficiency of surgery. Last part means, if you look at the Oxford University, surgery means removal of organs or tissues. That is what he is referring to. And he went on to say that it is like an armed savage who attempts to get that by force, which a civilized man would by stratagem. What a beautiful statement. This he said because at that time surgery was in an infancy, and you know the history of surgery, that can be a subject of talk by itself. We were described as barber surgeons, was not even permitted to wear the white overcoat. But later developments made surgery a vigorous specialty by itself. And there were a large number of technological advancements which increased the scope and complexity of surgical procedures. We need not think that it is exclusively because of development in surgery alone, but also other disciplines, because the three major problems surgery faced was pain, bleeding, and infection. And infection was controlled by antibiotics, and pain by drugs and anesthesia. And also you should understand that even though Alexander Fleming discovered penicillin in 1928 in St. George Hospital, but it was marketed, purified and marketed only in 1942. That is to say that the whole period of medical advancement is roughly about 4 or 5 decades. Well, and so surgery became a very rigorous specialty. But now if you look at the 21st century medical science as a whole, tremendous advances are being made last 30, 40 years. There is a knowledge explosion. We always talked about knowledge explosion. If you look at history, when agricultural revolution happened and followed by industrial revolution, we talked about knowledge explosion. But the rate of knowledge explosion is increasing now. It is said that, paraphrasing what Professor Sambashivan said, it was said that if you want to be in the same place, you have to keep on running. Now we say that if you want to be in the same place, you have to keep running at a faster pace. So knowledge explosion is taking place maybe by arithmetic progression earlier, but now by geometric portion. It is not 1, 2, 3, 4 way of developing. It is 1, 2, 4, 8, 16, 32. That is the way knowledge explosion is taking place. Now, more important is this particular thing, which is very important as far as this presentation is concerned. There is an integration, assimilation of biological, physical, and digital sciences that is happening across the border. Pharmaceutical, vaccines, imaging technologies, endoscopic procedures, artificial intelligence, and genomics. I have to tell you that that again can be a separate topic. We will be referring to it later in this presentation, that next 5, 10 years will be big genomic revolution. Whatever we are doing now, we may have to forget within, say, 5 to 10 years because of genomic revolution. Now, this is the situation. I don't like to project quotations much, but nevertheless, this is an excellent quotation. That is to say that it was possible for a surgeon who finished training in the late 1970s to have a 20-year or 25-year career with very little alteration of the technical armamentarium. That is to say that if you look back, you see that in one's lifetime, there will be one spike in technological revolution. So you master that, and then you can complete your lifetime. But now if you put a graph, you will have multiple spikes, multiple technological revolution. So this is that is very well said in this article, in these thoracic surgery articles. I will be showing some of these references in this presentation itself purposefully, because otherwise you may think that I am exaggerating this. I am actually quoting from reputed journals. Now another major development that has happened, that is what we were discussing last 2 days, is that imaging technology has come. That is not the only issue. The issue is that diagnosis and intervention has joined together. See, earlier the diagnosis, somebody makes a diagnosis, some technology makes a diagnosis. It is the surgeons or physicians who treat the patients. But now what is happening is that the diagnosis and intervention has integrated. So that is why I said disciplines, various disciplines are getting integrated. And therefore what happened was that it actually started with the cardiologist, not in the neuro specialty. There was a turf battle. This happened with coronary angiogram. That is to say, there was a tough battle between physicians and surgeons, the cardiologists and cardiothoracic surgeons. Because, see, there was a statement earlier. I hope that the physicians will excuse me for this statement. It was said earlier that physicians know everything and do nothing. And surgeons know nothing and do everything. And psychiatrists know nothing and do nothing. That was the classical statement. Now, what happened in the case of coronary angiogram was that angioplasty was done by the cardiologist. This is the first time that the physicians moved out of their prescription rooms and start doing a therapeutic procedure. So this happened. And later what happened? There was a fight between interventional cardiologist and cardiologist. Now there are many institutions where this intervention, angioplasty and other procedures are by interventional cardiologists. Now the interventional radiologists have come. I understand from Dr. Ishwar was telling me the other day that anterior communicative aneurysm they hand over to the radiologist for coiling. It's not so. So therefore, interventional radiologists have come. And that also has moved out. Now a new generation of specialists have come, exclusively interventionalists. So it is said that now if you look at most of these interventions, radiologic interventions for various diseases, if you have got a good video gaming skill, you can treat any patients. So the only skill that now is necessary is video gaming skill with which you can actually do most of these procedures. Now radiosurgery has come. Surgery has, see, earlier radiation was much looked down upon treatment modality, that it destroys all sorts of cells. Now we have radiology technologies that exclusively focus on the fast dividing cells. We have proton beam therapy and so many therapeutic modalities are there. There are image guided radiation therapy. It is called gamma knife radiosurgery. The term knife is used here to satisfy the ego of the surgeons. Actually there is no surgery is being done. You know that tumors, acoustic neuroma or even pituitary lesion, AV malformation, trigeminal neuralgia, or can be managed by the radiotherapist. So the gamma knife radiosurgery has come. Now I am telling you that if you had a basket of cases which you are managing, I am taking this basket, emptying this basket. So at the end of the day, there will be very, very few conditions that remains in the basket, which we were managing earlier. Now, these technologies are called disruptive technologies. Disrupt the workplace routines, which we are used to. And these type of technologies are threatening the existing surgical skills. So we are all very proud of our surgical skills which we have. Now all these disruptive technologies are threatening our surgical skills. Now let us look at what do you mean by disruptive technologies? There are two types of technologies. I am talking exclusively on medical technologies. One is called sustaining technologies. That is what we were doing. Like conventional open surgery is a sustaining surgery, laparotomy or craniotomy. These were our bread and butter procedures. Basically, surgeons were cutting and sewing, removing and sewing. This was exactly what we are doing. Ectomies and otomies. So these are called sustaining technologies. Just remember what we are now doing or what the phase we are doing. Now we are moving on to the disruptive technologies based upon imagiology and minimally invasive procedures, artificial intelligence, robotics, telesurgery, etc., etc. So these are simpler, are more convenient to use. So therefore you see that we are now facing large number of disruptive technologies. And this is the core message which I want to convey in this presentation. That the surgery is facing a paradox. Because earlier we said that from barber surgeons to a respected medical specialty, surgery developed because of technological upheaval. But exactly the reverse is now happening. What is now happening is that the emerging disciplines and technologies, and because of that we are doing fewer and smaller surgical procedures, downsized in scope, indication and in invasiveness. Now we have statistics available, you may not believe this. Now in Western countries, surgeons generally do 30% less hand-on procedures as which they used to do about a decade back. This is actually happening. Now, this is an extremely interesting article which I would suggest the younger generation to read this, by Lawrence Rosenberg, who is the professor of surgery in McGill University, with his colleague Schilch, who belongs to the social medicine department there. 21st century, very good review article, wherein he makes a very provocative statement. He said that surgical discipline, as we have known it over the last 150 years, may be in the earliest stages of dissolution, a victim of technological progress. In fact, one of the paragraphs of this very interesting article is titled "The Rise and Fall of Surgery." In fact, Mohanlal asked me to title this presentation as "The Rise and Fall of Surgery" to provoke the audience. Okay, this is what he has written. Well, therefore, see, we have to view what we are doing from outside. You stand outside and you actually when we are within, we may not realize what we actually are doing. Now, this is what is exactly happening now. There is a traditional surgical workplace, strong occupational culture, principles of surgical judgment, and good hand and large incisions. Big surgeons make big incisions. That was a surgical axiom. But now big surgeons hardly make any incisions. It's not so. If you make big incision, nobody will consult you. So that was in fact, I want to make a presentation on the changing medical axioms now, because many of these axioms are changing. You know, I have recently read a book which is Ubiquity. The name of the book is Ubiquity, wherein they are comparing human beings with animals. What are the difference between human beings and animals? So somebody will say that the laughing animals are human beings. Then we will say there are 13 animals who laugh, something like that. So finally they came to the conclusion that the only difference between human beings and animals is that only human beings can handle the barbed Parker knife. Now, hardly we hold a barbed Parker knife. I do not know whether the new generation has actually seen a barbed Parker knife. So that last vestige of difference between human beings and animals have disappeared because of technological revolution. Now, the modern surgical workplace is this. The surgical act has moved from a direct tactile environment, you see, to a video screen environment. It's totally different, because here you can see a surgery, endoscopic surgery being done. So their eyes are glued onto the screen. Here is a robotic surgery being done. So therefore, we are moving from a tactile environment to a video screen environment. And there is a paradigm shift in surgery. This is happening. We are all doing it, but this is exactly what is happening. From individual responsibility and control to group coordination strategies. Dr. Sambashivan, Dr. Bill Roth, all were kings in the operation theater. That is no more there. In fact, there is a video. There are so many other technologies. Technologies are there to. So it has become from an individualistic approach to a group activity. From an open surgery skill are different from this type of skill. It is earlier we had an interpretive skill. Now it is a hand-eye coordination skill. So the skill development, the skill set has completely changed. Now this is the essence of what is now happening. That is, if you look at the whole picture, from direct hands-on to indirect hands-off technologies. That is to say, computer-aided, catheter-based, robotics, telesurgery, etc. Minimally invasive also is shifting to non-invasive type of procedures. See, all these radiosurgeries are non-invasive type of procedures. And also, we earlier were following this type of procedures, unimodal resection reconstruction. That was the original surgical procedures. But we have multimodal therapy, a biologically tagged image-guided procedures. Especially this biological tag comes in genomics. We will mention about this in a minute now. Now the genomic revolution is happening. I can tell the juniors I am not talking about neurosurgery in general and medical science in particular. Whenever I go to any medical college, I ask youngsters, what do you know about molecular biology? Our molecular biology knowledge is very poor. So unless you learn molecular biology, you will not be able to practice medicine in the future. Because this is what is happening. There is a prenatal, postnatal and pre-implantation diagnosis which predictive medicine is developing. We can actually predict by examination of fluids from abdomen from a pregnant lady. And now already fetal surgery has come up like of course in hydrocephalus, in the pregnant stage itself or in spinal deformities. Or you can do the CRISPR technology, do genetic manipulations and change most of these congenital anomalies at this stage itself. And then of course there are designer drugs, but most important is gene therapy and regenerative medicine or stem cell therapy. You have to develop the stem cell lines, and many of the diseases will have a total cure. In our case, it may be spinal cord injury. If you develop the cell line, we can actually create neurons, and then this can be treated. It may be a days, it may be a few months, maybe 1 or 2 years. This is happening because large number of countries, thousands of scientists are working on this. But I will just mention one very important area also here only. In fact, I think Dr. Alapad was just mentioning it in passing. I would like the PGs to read this paper. It's an excellent review article on gene therapy in glioma and gene therapy in malignant diseases in general. Excellent article. In fact, in 2013, I made a presentation in Pushpagiri Hospital in a conference, the Travancore Kairali conference organized by Dominic Ando, where I made a presentation on genomic treatment of gliomas. Now, a 2021 article has come, where they have updated the whole thing. I would like you to read this article. Now, what is happening is this, and I cannot go into details, that can be a talk by itself. This is the therapy that they are now trying in gene therapy in malignant glioma. It is called HSV-TK ganciclovir therapy. HSV is, see, most of these are virus which are fitted with some gene, you see. This is a genetically modified viral therapy. This is what exactly we are doing in the vaccines we all have taken, Covishield vaccine for COVID prevention. This is exactly they are using. What they do is a herpes simplex virus fitted with a thymidine kinase enzyme. A thymidine enzyme, you know that it's a cytotoxic enzyme. And then this is given by intrathecally, or we can give it intratumorally. And then ganciclovir is acyclovir derivative. It is called a prodrug for this particular treatment. What is happening is that once you give this, the ganciclovir will be converted into thymidine analog by the thymidine kinase enzyme by the fast dividing glioma malignant cells. So therefore, this thymidine analog will interfere with the DNA synthesis, which will lead on to cell death. Since the malignant cells themselves do this, this is called suicide gene therapy. And this is happening actually, in fact, in the latest paper I have referred to, they have published the results. These are the HSV-TK ganciclovir group, and this is the control group. You can see that the glioma, highly malignant glioma, has been fairly well controlled in this group. So therefore, what I am trying to say is that genomics is going to change the way we are managing some of these things. Our craniotomy, debulking, radiotherapy, chemotherapy is going to be out very soon. It's already on the move out. So therefore, if you put all these changes into neurosurgery spectrum, we have been discussing last 2 days, we have minimally invasive neurosurgical procedures, and fiber optic cable has made the major difference in endoscopic procedures, stereotactic procedures, neuroendoscopy. Now I was remembering Dr. Mahadevan was here. With Mahadevan's help, I used to operate for CSF rhinorrhea. We have done about 12 cases of CSF rhinorrhea. What do you do? Bifrontal craniotomy, lift the frontal lobe and do the surgery and the depth. And the problem is that if you fail in the surgery, the next day the patient will understand the surgery has been failed, and the patient develops a lot of frontal lobe syndromes, etc., etc. But now I have listened to a presentation by an ENT surgeon in a neurosurgery conference where they do it in transnasal approach and they repair it. That is the broad spectrum ground. And virtual reality, radiosurgery, and gene regenerative. So all these are influencing neurosurgery also. We are not in the stream. Even though I have titled it as surgery, it applies to neurosurgery also. Now, this is the issue. We were earlier treated as mere technicians, you see. Surgeons were called proceduralists. But now the situation is that, are we becoming non-surgical proceduralists? Because many of our old surgical procedures are going to be out. It's already out, so obsolete. So are we going to be described as non-surgical proceduralists? This is the problem we are facing actually in all medical specialties. So therefore, what we have to do now is that if we are, what should be our future role? I mean, this should reflect in all our conferences. That is to say that we have to master new technologies, disciplines and concepts. It's not only that technology. See, we organize hand-on technological workshop pre-conference. We should do it. First of all, we do that because technologies are changing. That is the reason why, because in the formal education, we cannot update, and therefore we organize this. But not only that, concepts are very important, concept and disciplines. So we should have a first mover advantage. See, the cardiologists failed because they did not have this, they did not notice this, they did not have the first mover. That is why angioplasty was taken over by the cardiologist. The cardiothoracic surgeon failed in that. So they had the first mover advantage. So that is why cardiologists started doing angioplasties. But we should have a first mover advantage. Suppose we don't do that, the effect will be a bystander status. Anyway, things will change. We will be only onlookers. Things will anyway are going to change. I am not exaggerating. That is why I am purposefully projecting these papers which I am depending upon to make this presentation, is because I am not exaggerating. This is exactly what happening. And last but not the least, see, medical science after all is a human-centric discipline, you see. Are we becoming technocentric, more and more technocentric? Are we getting dehumanized? And therefore, I still remember, I always tell Professor Tandon, sir, I am quoting you without your permission. Because, you know, when CT scan came, it was named CAT scan, computerized axial tomograph. We started making mistakes. We stopped examining our patients. We just started ordering CT scans. You know that in neuro specialty, the problem is that we have to localize the lesion. See, in another specialty, the localization issue does not come. A lesion can be from nerve ending to brain. So it is from history and clinical examination, you first localize. So we wrongly localize lesion. Brain, instead of doing a spinal CT scan, we started doing brain CT scan, and we started making mistakes. So Dr. Tandon became, in one of the neurosurgical conference, I don't know whether Dr. Srikumar was there, he became very frustrated. He said, made this statement, which I always remember. He made this statement that man scan is better than cat scan. So he made this statement. So it has to be a humanistic. So when we talk about all this technological revolution, we should not forget that after all, we are treating human beings. We are treating diseases. And therefore, we are still in. I am trying to say is that no, surgeons are not out. We are still in because we are treating human beings, provided we have a humanistic approach. And therefore, I may suggest that the surgeon's role should be more than a technician. So if you look at it from a purely technical point of view, we are going out, but not so. Not to be confined to the operative care. We should develop broader skills of managing diseases. Understand? And with an ethical health delivery. That is, we have to change the whole philosophy of surgery. So that, therefore, of course, we are threatened. We are facing problems. But then we will have to change the philosophy of surgery. Now, if you then, whatever I have said here, to reduce it into a few sentences, I would say that surgery, as we know, is going to disintegrate. If our ego is hurt, I will use the term transformed. See, in fact, the original papers, all the papers mentioned about disintegration. They say that it is going to be out. So therefore, all written by surgeons. Lawrence Rosenberg is a professor of surgery in McGill University. He is still there. So surgery, as we know, is to disintegrate. But it will get, to me, I would rather use the term transformed rather than disintegration. So we will have to reinvent ourselves. See, we are come in this very traditional mode. We will have to reinvent ourselves and upgrade knowledge, not only technical, but the humanistic skill sets also. That is a separate skill set altogether. And then we should have high moral philosophy and performance. So therefore, I won't say that I am not with Lawrence Rosenberg and others that we are going to be out. We are there, but the whole surgical philosophy has to change. Friends, I am finally ending this presentation with a quotation from Richard Seltzer. I said, as a speaker, generally I don't like quoting from books. It is not a good way of making a presentation. Richard Seltzer was a professor of surgery in the Yale University. He just died. He died in 2016. He has written a large number of books. I would advise youngsters at least to read them. One of the title of the book is very provocative, Confessions of Knife. It's the title of the book. He has written, he's a surgeon, not a neurosurgeon, but a general surgeon. And he has made a very poetic statement, which always captivated me. See, there are certain statements which captivates you, which always keep you haunting. That is what when Dr. Sambishan said, a pat on your shoulder will keep you sleeping and a kick on your buttocks will keep on running. I always remember. And I always remember Tandon saying that man's scan is better than cat scan. So similarly, this poetic statement should satisfy we should congratulate ourselves. The surgeon is an explorer in the tropical forest of the body. How beautifully put. This is one of his less known book, Letters to an Young Doctor. In fact, this book is exclusively written to internists. Young doctor means internist, worth reading. So he said this, the surgeon is an explorer in the tropical forest of the body. Friends, when I wind up this presentation, I have 14 more minutes more. So very short presentation. Because it is very intimidating, so I never looked there. See? So it is very intimidating, you see, you will be frightened. So I never looked there. That's why I'm closing it at an earlier time. Professor Sambishivan, as I see him, paraphrasing Richard Seltzer, I would say that he was an explorer in the tropical forest of the nervous system. Thank you.
I would like to request our chairpersons to please hand over the memento and certificate. Thank you, sir. And thank you to our chairpersons. We will be commencing with our next session. I would like to invite Professor Girish and Dr. Dev Prasad to be the chairpersons. At the end of this session, we will be having our Kahoot online quiz. Please note, it is not only for students, but also for our senior neurosurgeons and neurologists. It is assured that it will be quite fun. There are only 20 MCQs. All of you will be able to participate using your own mobile phones. The fastest finger first, where you will have 20 seconds to click your answer. In your final result, the first, second, and third prize winners will get a cash award of 4,000, 3,000, and 2,000 rupees each. In the interim leaderboard, members will also get prizes, where the leaders after 5, 10, and 15 questions will get 1,000 rupees each. There are no negative marks, and it will only be for 20 minutes. So I request all faculty, delegates, and students to please participate with your phones at the end of this session, where you can participate either with your own name or with another code. You do not need to download any application. All you have to do is search for kahoot.in, KAHOOT.in, and enter your name and you will be participating. Thank you. We will be proceeding with our next session. I would like to invite Professor Paritosh Pandey onto the stage.
Friends, thank you very much, Dr. Jacob and the team, to indulge me. I'm very nervous because I'm coming after Sachin Tendulkar and Brian Lara, and I'm basically a very low-level batsman in Ranji Trophy, so I'm extremely nervous. So please indulge me here. I would be, this is not a talk to be either preachy or critical of anybody. It is rather a talk which came out of some introspection. And I have no claims to wisdom, ethical knowledge. I'm not sitting on any high horse. I have created all kinds of complications that is known to surgery and more. And I have no lack of any temptations. It is just a few thoughts looking at rapid commercialization. There is unindicated and surgeries and procedures which are rampant and getting more and more popular. There is tremendous pressure that the neurosurgeons worked on, as Dr. Iqbal said, that the surgery is getting apoptotized, as in the medical terms, and we want to still have our livings and everything. And there are, let's face it, there are multiple temptations and incentives. So if any of you have gone to a Hindu puja, they will always end with what we call as a Shama mantra, which is basically a apology mantra, which goes like this: mantrahinam kriyainam bhaktihinam tadastume yat pujta mahadevi tastu. Basically, that means that I don't know any mantra, I don't know any tantra, I don't know anything like that. But whatever I have said, please indulge me in this and promise. So this is the mantra I will tell you before I say this. So it's basically a broad term that covers the study of nature, and how much ever technically superior may be, the ethics is completely intertwined with the medicine. It is there from the absolutely beginning of medicine, and even if everybody robots keep on doing all this thing, we will have this kind of ethics, and medicine will be married together for eternity. And we have two types of morality. There is common morality, which basically means that you don't steal, you don't kill, you don't do these things, you don't do adultery, all these things. And there is particular morality which is forced, or we choose ourselves when we become a doctor. We have the ethical obligation to benefit the patient, to avoid, minimize harm, and to respect the values and preferences. So since the beginning, there are four major pillars then that the ethics is standing on. This is called beneficence, non-maleficence, autonomy, and justice. First to have been there since age-old method. So basically, beneficence is why we became doctors. We want to do good to the people. So we, as surgeons, we want to do good to the patients who have back pain, brain tumors, subarachnoid hemorrhage, all these things. It is our duty to provide good. And that is what led to what we will come to as paternalism. At the same time, there is also a often conflicting principle which is called as non-maleficence, which basically means first do no harm. But that's really not possible in a large number of situations, because to do the first principle, we have to do some harm to the patients as well at a lot of times. This came much later. This came in almost 17th, 18th century, and the maturation of this thing has happened only after the Nazis did a lot of experiments in human bodies. So it basically, John Stuart Mill, Locke, Immanuel Kant, all these people recognized that all the people, just by the virtue of being alive and being born, have intrinsic and unconditional worth, and hence should have the power and to make rational decision and moral choices for themselves. So this is a very, very important principle that we have started to recognize just now. And we now recognize that every patient has autonomy of his own body. Even if we want to do good for them or not do bad for them, they are the ones who are choosing here. So that led to these kind of principles like paternalism, where we thought we could dictate terms, or consumerism here. And then of course there is justice, that we want to be fair, equitable, and appropriate treatment to the patients here. So these are the four major principles: autonomy, beneficence, non-maleficence, and justice here, right? There are other principles. There is something called informed consent. Then we have to be truthful to the patient and ourselves. And then there is principles of confidentiality here. How do we make decisions in medicine? So initially, first we started to do, I have studied medicine for 12 years. I've been practicing medicine for 20 years. I know what is good for you. Please do this. I know better than you. Then there is something called as informed decision making at the other end of the spectrum, where I tell to any patient that these all are the options. I will tell you the pros and cons of all these options. You please make your own decisions here. And then in between somewhere is there something called as a shared decision making, which is basically you and the patient together recognizing the various problems that both of you are in, come to a shared conclusion making here, right? So this is a collaborative process between both doctors and the patients, and the decisions are made by medical knowledge provided by doctors and patients' values and priorities. So this is a big deal. And then we can make a various kind of decision analysis after some times as to whether what the decision making that you're doing is correct or not. Now in neurosurgery or in any other surgical specialty, there is always a problem of balancing the efficacy and safety. So an efficacious statement can also be more dangerous. A safer treatment can be less efficacious. So if you take an example of a skull-based meningioma, if you want to remove everything, that is probably the most efficacious treatment there, but less safe. And if you leave a lot of tumor, it can be much safer, but less efficacious. So we have to balance all these things. We have to do best to our patients, and we also should minimize the influence of the external factors and incentives. The problem here is that there is a large amount of information asymmetry between the doctors and patients. So even if you spend 1 hour, 2 hours, 3 hours with the patients, there is no way that the patient can come up to your level of information. And that you recognize when you are at the other end of this spectrum. So if you become, or your loved one becomes a patient, even if you are a doctor, you're a neurosurgeon, and every one of us will face this, we will tell the doctor, you do what is best for my patient. At the end of the day, you have all the information in the world. So suppose if as a doctor I have this kind of information asymmetry, suppose there is a cardiac problem, I have an information asymmetry between myself and the cardiac surgeon or cardiologist. So this cannot be bridged here. There is a large amount of quote-unquote unethical practice going around all over the world. There are experimental treatments being given, unnecessary procedures which are all over the town. And there are a lot of times when we hurry up the procedures, as in say, it requires urgent surgery when you can have completely. And this happens all over the world, wherever there is commerce involved in the treatment, or there are other kinds of incentives, right? There will be a doctor who wants to clip the maximum number of aneurysms in the world, or there will be a person who will have the maximum number of CVs. So incentives, don't just come in money, they come in all kinds of ways, and often we don't recognize this. Now, there are many problems in decision making. Medicine is not mathematics. As sir already said, 2 + 2 is seldom 4. There are 10 ways of treating the same disease, and all 10 is correct. It is not possible that I will tell that my way is correct way and your way is not correct way. Medicine is also a contract between the patient and a doctor, individual contract between patient and a doctor, and the third person has very limited way to say that you are correct or you are wrong. It is also very much about probability. Even a simple thing like COVID vaccine is about probability. It reduces the probability of severe death and disability, but at a small cost. So every surgery that we do is about reducing the probability of something bad happening at you, at the risk of something very, very bad happening to you immediately. And there are, of course, complications. We quote complication rate of 1%, 2% or something. But for the patient who has these complications, it's 100%. So these things are mere statistics and you do nothing. Of course, there are multiple treatments of any diseases. Just take a simple lumbar disc. You can give prolonged medical treatment. You can give root blocks. You can do discectomies of all kinds, which can be prevalent or non-prevalent. You can do fusion. You can do artificial disc. In all these patients, the doctor is right. He is not wrong. He or she is not wrong. All these treatments are correct treatments of a simple lumbar disc here, and there is no way we can criticize the doctor or the patient here. Here I will tell you the story of John Rawls, who wrote this beautiful book called Theory of Justice, which is a classic here. What he was trying to do is to say that there is no way there can be equality of various people. Some people are more powerful, some people are more rich, some people are men, some people are women, some people are higher caste, some people are lower caste. So how do we make a natural law which will be acceptable to all the people? So what John Rawls said, that there should be everybody should put themselves behind a veil of ignorance. What it means is that we don't know we should put a veil as to, suppose we don't know what our role in society will be. So suppose I don't know whether I am male or female, whether I am high caste, low caste, whether I am rich or poor, whether I am this or that. And then we make a set of rules that will be acceptable to me even at that point of time. So I will make a rule that will be just for everybody. In the same way, and we all know this golden rule that do unto ourselves that you would do unto yourself. What I think is the basic principle of that will be starting point of the decision making is when we inverse the golden rule. We should never do to a patient as what one would not do to oneself. So here what we are doing is, I know that there is, when I put myself in the position of a patient and myself at the position of the doctor as well, there is no information asymmetry amongst me. So then I will make the most rational choice that will be in my hand. All right. So basically, the golden rule of surgical decision making would be like this. If as a doctor, I would not undergo the procedure that I am proposing, had I had the same disease, I should never propose that procedure actively. All right. So we put ourselves in patient's shoes and think if we would undergo that procedure that I'm proposing. If the answer is no, we should never do that. And that is the basic starting point of any decision making. And that I can tell you by various kind of examples like spine or aneurysms or scoliosis, experimental treatment, petrocalcium angioma. Suppose a patient of scoliosis comes to me and I do not have enough experience of this. It is, at one point of time, it is like business for me. But I know in my heart that I will not be able to do justice for him, so I will not do that procedure itself. If you apply that rule to yourself, if you project your patient as you, and then start to make decisions here, then there is very little time when you will have a wrong or unethical decision on your part. I mean, at least, as somebody said, before you lie to another, you must lie to oneself. So as long as we will not lie to ourselves, we will not have these problems here. Of course, there are many problems here. There is bias there. there is very difficult to imagine oneself in patient's position. We always have an inflated sense of worth in the surgeons here, and introspection illusion can be very difficult to combat here. Even then, this approach that you put yourself in the patient's position and then have a decision best decision as to what we are making, will address all the components of ethical and decision making, which is beneficence, non-maleficence, autonomy, and justice, and will help us make better and ethical decisions. As somebody said, ethics is knowing the difference between what you have a right to do and what is right to do. Often when we are not involved in the position, we always think about the former as to what we have a right to do and not what is right to do. And once we marry these two things of what we have a right to do and what is right to do, then it will come as ethical decision making in medicine. With these words, we invoke this prayer, and thank you very much for your kind presentation.
I would like to request our chairpersons to please hand over a memento.
I have got a moment.
So,
Please.
Yes, please.
Paritosh, wonderful. That was an excellent talk. I know you only since yesterday, but I've developed a liking to you. You are from Bihar. I did my MBBS from Bihar, so there's a lot of common things. Now, a few things I want to make comment. Number one, there is a dictum I have developed. I'm not saying that is correct, but there is a dictum I have developed which I would like to share with my junior colleagues if anyone is there. Whenever there is a decision-making problem in brain or spine, there is a dictum I follow. I think of two things: what is possible in this patient, what is necessary, and I choose the less invasive, and it's always correct. Like your lumbar disc example you said. What is possible? Artificial disc, fusion, single level, multiple level, A-leaf. What is necessary? Decompress the root. So choose the lesser. Sphenoid wing meningioma, aneurysm, anything for that matter. What is possible versus what is necessary? Tablet. Choose the lesser invasive, you are almost always correct. The other thing is that one of the very famous quotes from Bible, Matthew, you said, do unto others as you would like to do unto yourself. But now we have become so degenerate, we always think, do unto others before they do unto you. Jokes apart. The final thing I said that is a very valuable thing that you said that when you have a patient with a particular problem, you always think if you are the one, would you subject yourself? I mean, that's a little tricky, I tell you, because if I get a problem, I will definitely go to a surgeon better than me. I will never let myself operate. Myself means a man of my caliber. I will always find someone better than me. So it's a little tricky situation there. But I got the message that you are driving at. Thank you very much, Paritosh.
Thank you. Thank you.
Thank you, Dr. Paritosh, for a very emotive talk. I think as you grow older and older, you tend to become wiser and wiser. And from a hardcore, vigorous, enthusiastic neurosurgeon, you tend to become more and more conservative. One of my friends, ENT colleagues, used to say, when I started my operative practice, I was like famous who was that batsman who used to hit at our own Sehwag, Virender Sehwag. So initially in my practice, I used to be like Virender Sehwag. Any patient who comes, just give it a go, operate. And then subsequently, in the middle of my career, I started becoming a little more circumspect, and I started becoming like Sachin Tendulkar. I will take the safe balls to hit, and then the loose balls, just leave it like that. And finally, towards the end of my practice, I became like Rahul Dravid, became the wall. So start defensive practice. So things have come to a head where we are becoming more defensive, but ultimately I think, like Paritosh said, If you follow ethics, I think that will be the guideline for all of us as surgeons. Thank you.
And there's a quote by Hutchison also regarding the same thing. From inability to let well alone, and the last part is, from making the cure of a disease more grievous than the endurance of the same. Good Lord, deliver us. It's almost the same thing. Yeah. Thank you very much for your very good talk.
Thank you. Our final speaker is Dr. Jagatlal Ji, an alumnus of Calicut Medical College. He has both trained in and worked as a faculty in NIMHANS. He's a multi-talented neurosurgeon and is currently Chief of Neurosurgery at Rajagiri Hospital, Alova.
Thank you for that introduction. And we always see that great achievers in science like Einstein, they all become good philosophers, and they reveal all their philosophy through their writings. And now we saw Dr. Paritosh, who is incidentally my teacher in NIMHANS. And here I start my topic, MRI guided focused ultrasound, expanding frontiers in neurosurgery. At the outset, I'd like to thank the organizers of Malabar Neurocon, Dr. Jacob Alapat, who was my first inspiration, just like my first love, we can say first inspiration in neurosurgery. And during my MS period, he inspired me to join this. And Dr. Rajiv, with whom I did my first brain abscess, frontal abscess, I still remember that, and the whole team of neurosurgery. I'll start with a small video.
I can't write anything that you can read.
Hey Don, are you okay? Everything's going very well, okay? You said there are 980 elements to the virgin right there.
95% improvement, at least.
Wow. He did.
So you could see that within minutes of treatment, that person's tremor stopped. And there is a wonder of science now. And you could do without any incision, non-invasively. And this scholarship took me to Morgantown, where it's being done. And that is the Rockefeller Neuroscience Institute. And this is where the first in the world to use focused ultrasound to treat a patient with Alzheimer's disease. So the technique of focused ultrasound is available worldwide. There are many centers all over the world doing that. And it's used in various other departments like, for example, fibroadenoma, prostatic surgery, pancreatic surgery. And then it has naturally come into neurosurgery also. So it was in 2016 that FDA gave the first approval for focused ultrasound device to treat essential tremor. And later in 2021, it added Parkinson's disease tremor also into the anvil. Now coming to tremors, you can see this is the person who draws an Archimedes spiral without any tremor. And then there are two kinds of tremor. When there is an essential tremor, it's more coarse, it's more horizontally placed, and then the Parkinsonian tremor. So my study was focused on the evolution of the surgical treatment for drug-resistant ET and tremor-predominant PD. So as you all know, the initial treatment for tremor was lesioning in the thalamus using either radio frequency or gamma knife. And then came deep brain stimulation, which is still the gold standard, and now with HIFU or high intensity focused ultrasound. We'll go a little deep into this, and first we have to understand what is the target. The target for tremor treatment is ventral intermediate nucleus of the thalamus, VIM, and you have an indirect method of targeting based on certain measurements from the midline and from the ACPC, drawing the ACPC or the commissioner points. There is a direct method of targeting based on tractography. So finally, we have to identify the VIM and then target it and do the treatment. So what are the treatment? One is placing a lead as in DBS and stimulating it and suppressing it. And second is using a focused ultrasound and lesioning it or burning it off. Now coming to the basics of focused ultrasound, an ultrasound is something more than 20,000 hertz, and it can pass through anything, even through the gas, but then the way or the speed by which it passes can be different. And then it can get reflected or even attenuated by the medium. So how to correct the skull distortion, how to penetrate the skull? and there came the development of the phased array. Or if you see that if there is a delay between the generating transducers, so here this wave started first, and here it started later. So you can give in an angle, and various modifications are given to penetrate the skull. Modifications not just on the phase, but also on the intensity, the time of ultrasound, etc. Now, guiding or fusing, merging an MRI helped in an excellent resolution to know what is the normal structure where we are targeting. So it also helps to measure the temperature which we are developing. Now comes to the action or the biological effect of ultrasound. The first one is a thermal effect leading to heat generation, as in the lesioning. The second one is called acoustic cavitation. That is, the oscillation of the microbubbles will cause a cavitation effect inside the tissue. And the third one is acoustic streaming. These radiation forces will cause a tissue strain and damage the local focal tissue, just like opening of the blood-brain barrier. These kind of changes are often transient. So with these three effects, all the uses of ultrasound are, this is how ultrasound is used. Now coming to first one is thermal ablation. As you know, when the ultrasound focuses on a point, it gets heated up to 60 degrees Celsius, and you get some cells which die down, and if you focus it, it can make a good lesioning. So here, when you use a high intensity focused ultrasound, the tissue is ablated at the point of the sound wave convergence. However, the pathway is totally unaffected. Now coming to some technical details, there is something called a skull density ratio. That is, if the skull density ratio is lower than 0.35, the wave will not penetrate the skull. It will stay there. It will leave all the energy, dissipate all the energy into the skull and heat it up, so that we have to stop the procedure. So you can see these are the transducers. So in a SDR is high, like a skull like this, where the cortex is very prominent. You can see all these transducers are working. Whereas SDR is low, where the marrow is also very deep, only very few transducers are working. So technically, we have to do a CT scan for the patient, and you can select the patient who can undergo the procedure. The frame is fixed, and then that's a Lexel frame. This diaphragm is attached to the head, and then it is put into a helmet, and this helmet is filled with water, cool water, and then the ultrasound is given through 1024 ultrasound transducers, just like gamma knife, and then it's focused, and you create a lesion as of the shape of a rice grain. So this is lesioning effect. So this is another software which we can see that some areas like the air sinuses, some oblique areas, the focusing will not happen properly, and these are red points. The ultrasound goes through all these green areas, and can you see here, this green area is where the treatment can take effect, but mostly in the central part the action is most. And here this is the thermal scan which shows the radiography. And then how we do it is that we give lower sonications or raise the temperature up to 45 degree and check for any clinical effect. Is the tremor coming down? And then the side effects are also monitored continuously. Once the target is confirmed, you go to make the permanent lesion at 60 degree. So this is one case where the MR thermography is used to measure the temperature. Now there are some adverse effects consistently with thalamotomy surgery. One is sensory, headache, if there is skull heating, unsteadiness of the gait, and rarely cavitation. Can you see here, when the ultrasound wave compresses, the molecule becomes smaller. And if it's the other rarefaction, or when the wave is not there, the molecule will become larger. So this is called a stable cavitation. But you see, if the energy adds up, it can even burst, can even cause hemorrhage. Now these are the cases which analyzed for side effects. If you know about the anatomy here, if the medial lemniscus tract is aggressed by the thermal effect, you can get sensory side effect. You can get motor side effect when the cortical spinal tract is involved, or even gait side effect when the dendrothalamic tract is involved. So like this, you can find out what is the cause of a side effect. Now contraindication, like pregnancy, coagulopathy, and any non-MRI compatible device. Now this is one case which I witnessed there, and this is the cortical spinal tract, and they are doing the thermal map. This is the map that is being created, and then you can see the post-op imaging, the lesion. So this was the result, baseline, and this is the second case. You can see the Lexel frame, the diaphragm being attached to the head. The patient is wheeled into the gantry of the machine, attached to the MRI machine, and here's a workstation where we see all these things. And thermal map generation has occurred here. And you can see that there were 966 elements. Anything above 700 is okay. And see the time of starting the protocol, 11:01 a.m. And 11:46, patient is off table, just 45 minutes. And this is the result, pre-procedure. And this is stepwise lesioning we are just checking. And finally, post-treatment. This wonderful result is due to the non-invasive technique. Now coming to studies, there are 2-year follow-ups showing 60% reduction and 4-year follow-ups showing 56% reduction. So usually used in patients who cannot undergo DBS, elderly people. And then by 4 years, usually the tremor recurs. What is the future? There is a trial for bilateral ET treatment. FDA approval is awaited. Now the limitations are skull heating and the focus in the central part. Now what is the oncological application? As you know, the high-grade gliomas are usually in a sanctuary because of the blood-brain barrier. If you can break the blood-brain barrier, many chemotherapeutic agents can be used. So this is done using the focused ultrasound. It can be either mechanical disruption of the cell or the tight junctions can be opened and the drugs can be delivered directly. And now you have nanotechnology along with the FUS where special nanoparticles with cisplatin-coated nanoparticles which can go into the tumor and kill them. The other method is sonoporation, where each cell membrane opens up and some drugs, nanoparticles can be delivered. And there's a novel technique of a liquid biopsy of the tumor. So instead of going invasive, you can take a biopsy of a glioma from a blood sample. First through FUS, the blood-brain barrier and the tight junctions are opened up, and the glioma molecules can be diagnosed by DNA technique through the blood. Now, this is another kind of treatment for glioma, high-grade glioma, is immunomodulation. What happens in immunomodulation is that on focused ultrasound, the cells or the antigens of the tumor cells get opened up and they stimulate the dendritic cell, produces a cytotoxic lymphocytes which will target the cancer cell. So research is going on in all these fronts. Sensitization for radiotherapy. If you use focused ultrasound, you can reduce the dose of radiation and get more sensitization. And then sonodynamic therapy where sensitizers like 5-ALA can be used to cause epistasis. Now the last part of it is application cerebrovascular disease, that is sonothrombolysis. Focused ultrasound can help to non-invasively produce thrombolysis, and that is one technique which is there for a little longer time, and now focused ultrasound can help to use it in a better way. What is next in ultrasound? One is in the treatment of Alzheimer's dementia. As you know, the last year in October, Aduhem, one new drug has been used as a monoclonal antibody that targets the beta amyloid aggregates in Alzheimer's. So LIFU or low intensity focused ultrasound disrupts the blood-brain barrier and helps the drug to act more, and that is an ongoing trial. The second ongoing trial is on nucleus ambiguous, where LIFU helps to modify an opioid addiction. And these are the innovations that is happening in RNI. So you all know about this picture. It is in press now. So this is the green comet. You can all see it on February 2nd. It is called C2022E3. The last time it came was 50,000 years ago when Neanderthals were roaming around this world and human race was not there. And we don't know, the next time it comes close to the Earth, our entire species might have fully evolved into something else or even settle outside the Earth. So the future is something not something we enter, the future is something we create. So with this, I'll stop my talk. I'd like to remember the people in RNI, Dr. Ali Razai, Dr. Conrad, Dr. Manish Ranjan, and the multidisciplinary meetings that happen there where they select each case with a lot of precision, and not that just because they have a machine they go on with the case. And my sincere gratitude to my mentors in NIMANS as well. And this is a book by John Grisham on the tumor, and this is on focused ultrasound on neuro-oncology. Thank you very much.
One question. You said about the thrombolysis.
Yeah.
Is it MRI guided or just ultrasound based?
Actually, MRI guided only can reach the focused ultrasound vessel. But applications of thrombolysis I have not come across. It's just papers which I have seen on sonothrombolysis. Focused ultrasound always done, MRI guided. There should be a guidance for that. Yeah, it's 10 to 12 people.
So is it MRI guided or? Yeah, that's, yeah, that's right. Okay. Okay.
So this focused ultrasound is one thing they are bringing into it. Sonothrombolysis is used till, this paper is from 2012 actually. But now they are reinventing and putting focused ultrasound into it to give more force into that sonothrombolysis.
Thank you.
Thank you.
Sonothrombolysis actually was not done directly. They were doing TCDs to see, and along with that, what they found was like patients who had TCD along with the intravenous thrombolysis had a better outcome. But that was not proved on further studies. There was only one study at the beginning, but later on RCTs all proved that that type of thrombolysis which was done along with the TCD was not useful. So now maybe again good studies coming with the focused one. That was not a focused one. That they were seeing only for the TCD recanalization, and they were telling like, okay, those who had a TCD after IVT had a better outcome, but that was not proved, and that was not focused also. So that is why it has gone from the field. Maybe once you said the focused one, maybe a better use.
But just out of curiosity, you know, the diffraction of sound is higher than, say, when you're using gamma knife or something like that, is it not? So even if you use multiple arrays, won't there be diffraction or scatter?
Yeah,
will it be as precise as?
Biggest problem is scatter, and they have developed all these techniques to reduce the scatter. If you see during this procedure, even one air bubble can create a problem. When they make understand that also, and there are many methods to study that cavitation during the procedure. So they'll whenever there's an air bubble, they will cut off the transducer of that side. And then the total should be above 700, 720 to get a good effect, lesioning effect.
I know this catheter-guided lithotripters are available for thrombolysis.
Yeah.
So maybe it's going very close to the thrombus and doing lithotripsy and
yes. Actually told, there is one more research going on in neuro-oncology, catheter-directed focused ultrasound. I didn't bring into this, but I'm just saying, these are various things are happening. We don't know what's the future in all this. Thank you.
I would like to request our chairpersons to hand over the memento and certificate. Sir. Now we would like to conclude our session. Thank you to our chairpersons. We will be conducting our online quiz, which is being moderated by Professor Fiju Chako from Jubilee Medical College, Thrissur.
At the outset, let me promise you this will be only 20 minutes and fun. All of you can come to the front. We don't have a paper and pen to write. You need your own phones. Please come forward. Kahoot.it, Kahoot.it. You Google search Kahoot.it. This will be just 20 minutes, no negative marks, only 20 questions. At the end of 5 minutes, And 5 questions, 10 questions, 15 questions, there will be instant cash prizes. And the end of the session, there will be first, second, third prize. There are no volunteers, no audience. All are participants. All from seniors. Even our secretary is participating. All can participate. There is no audience. This is more fun, some information. Only common topics, not limited to neurosurgeon or neurophysician. Basic anatomy, some history, and some fun. You may come forward. Step 1, kahoot.it. Step 2, the pin is 30. Idana nammada pin idana. Binesh, this is our pin. 306-8459. That's our pin. You can do it in the app also. Kahoot.it. You will have first, you have to enter the pin 306-8459. Then you have to enter your name. It need not be your official name. It may be like Dev's or any pet name, nickname, CR7, Messi, Neuron, Synapse, anything. It need be a pet name. If 2 people put the same name, Rajesh, the second one cannot be taken. There will be 4 choices, red, blue, yellow, green. The question will be displayed here. Can we go back to the pin? 306-8459. 306-8459. Is your name included? Yes, you can see how many participants are there. Can you see? Ram Kumar, okay. Yes, we have so many names. Shanavas, Soumya, these are the participants. Can you see your name? We have only 33 people on stage. Peri Kanamo, okay? Rajesh ji, yes. You need not put your official name. Ashraf ji, secretary. Ille, adichille. HOD. Shall we start? We don't need any audience. We need participants because the fun is in participating. Dilip, you are in? Illengile? Daily we can't join. If all of you have joined, we can participate. You can come forward. The question will be displayed only here. Shall we start? Jnanadas sir. How many could join? At least 35 could join. This is a trial question only. This first one is a trial question. Anna. Ready? എല്ലാവരും കയറിയോ? ഇനി എത്ര പേർക്ക് കയറാണ്ട്? 1, 2, 3. ഒന്ന് ഹെൽപ്പ് ചെയ്യോ? Can you help? Jagatlal, could you join? Our code is 306-8459. 306-8459. Put in a nickname and then you are in. ഇല്ല, വേറെ ആളുടെ ഫോൺ എടുത്തോ. The first question we are on 305-469. 306-8459. This is the first question. The quiz is on. We have 10 more seconds. The BP is 210/120. The intracranial tension is 60. What's the? You have to calculate CPP, cerebral perfusion pressure, and enter. 9 have got it right. Can we have the leaderboard? BJ did it in few seconds. Who is BJ? Yes, very good. Down, right at the back. Sona Satyan. Even if you get the right answer, if you get it in 1 second, you get maximum like 1000 points like that. You have to get it as quickly as possible. The explanation, next slide. You can join, others can join also. Next slide. Cerebral perfusion pressure is mean arterial pressure minus the intracranial tension. Mean arterial pressure is diastolic plus 1/3 of pulse pressure. Diastolic here is 120. Pulse pressure is 210 minus 120 is 90. 1/3 90 is 30. So the mean arterial pressure is 150. 150 minus the ICT, the intracranial pressure, 60 would be 90. This is the toughest question. All others are going to be easy. Next, all are ready? Assess the volume, 3 into 4 into 5 centimeters. This is a bleed, what's the approximate volume? The choices will be on your question. Options will come in the, options will come. Yes. Options, 20, 30, 45, 60. Somebody is shouting and that is wrong. And the answer also is wrong. The length into breadth into height, 3 into 4, 12 into 5, 60 by 2. The answer would be 30. And 17, all the surgeons must have got it right. Next slide, the leaderboard. Again, BJ still leading, Sona close behind. Next slide. ABC by 2, length, breadth, height by 2. This is another question. In our problem, that was 3 into 4 into 5, 60 by 2 would be 30. That was the answer. If it were a cube, it would be a length, breadth, height. If it's a sphere, it would be 4 by 3 pi r cube or half of that. Coming to third question. What's the disease? Carotid occlusive disease. They have one limb shaking. It's a one limb shaking. It's actually a stroke-like, seizure-like. There is no Jacksonian march. It's precipitated by manoeuvres which lead to carotid compression. Often misdiagnosed as focal seizure. It's actually a stroke. What's the, you have to name it. Options. Is it Jacksonian march, epilepsia partialis continua, limb shaking, TIA, or echoria? In the options, A, there is the disease. B, treats the disease. No more disease after the correction. That's a limb shaking TIA. Vati coming. That's the limb shaking TIA. 28 have got it right. Now Sona Satyan has overtaken the leader. ASI, the flame. ASI has 3 in right. Who is ASI? ASI, yes, good. 3 in a row. Now coming to fourth question. That's the limb shaking TIA. Next slide. You have to name this extreme forward flexion seen in advanced Parkinson. What? One word for the extreme forward flexion in Parkinson. Is it kyphoscoliosis, Pisa syndrome, camptocormia, or a freezing? When they are sleeping, they are flat, but once they stand up, they are having an extreme forward flexion. There's one word for this. We have got 42 answers by now. Yes, that's camptocormia. The majority has got it right. It is indeed camptocormia. Leaderboard, please. Sona Satyan leading. ASI, MLN. Lal is our Mohanlal, sir? Allah, Jagat Lal. Yes. We have the Pisa syndrome, that's the lateral flexion. Next. Next. Coming to next question. You can write, but you can't read. It's not the bad handwriting. Where is the localization? Alexia, without agraphia, you write, but you can't read what you have written, not due to bad handwriting. Dr. Kurian, our footballer, is not here. In Jubilee, the worst handwriting belongs to NIK. Even he can't read. What's the localization? That is, majority have got it wrong. The answer is left occipital plus splenium. There's a disconnection. That's why you can't read. It's a left occipital plus splenium. It's not the angular gyrus. Next slide. Lal, Jagat Lal has overtaken. Yes. Now, question 4 or 5? Fifth over. So, fifth over, we have a prize for Lal, Jagat Lal. Shall I invite Harun sir to give it to Jagat Lal? Cash prize of 1,000 to Jagat Lal. 1,000. Like the Jaldi 5, first 5 in a Tambola. Yes. Yes, sure. There are no audiences. All are participants. That's where the fun is. So, next question. Doctor's bad handwriting actually kills people. Expressed breast milk was written and somebody gave a prescription also. Somebody gave a drug, some medical shop. Next, there's a disconnection. Splenium plus left. The sixth question. What is wrong about breviracetam? 30 times more affinity than levetiracetam, better rapid brain penetration, inhibitive properties on activated calcium channel. It binds differently than levetiracetam to SV2A. The answer is no action on calcium channel. That's why it has less of behavioral side effects. It has better affinity, it has quicker action, it is different compared to LEV. It has less behavioral side effects. In LEV, if it is 15%, here it is 3% only. So only 9 have got it right. Next slide. The leaderboard, please. Lal still leading. Flora is climbing high. Who is Flora? Yes, you have jumped 13 places. Next slide. Seventh question. This is a congenital anomaly of the vasculature. There are arrows pointing it. It resembles a Greek letter. The options. Is it persistent trigeminal, persistent hypoglossal, persistent acoustic, or a fetal PCA, fetal posterior cerebral artery? 4 options. Yes, it's a persistent trigeminal. Fetal PCA, it's actually MCA plus PCA. Middle cerebral plus the PCOM continuing to supply the posterior cerebral. This is a persistent trigeminal. It resembles the Greek letter tau, like a T. Next slide. Lal maintaining a good lead. Huck is the highest climber. Huck is our Huck. Huck et al., my batchmate. So, next slide. It resembles the Greek letter tau in a persistent trigeminal artery. Next slide. Next slide. Identify this test. Tinel, Fallon, Edson, Finkelstein. I hope nobody makes a mistake here. There are 42 participants. 42 have left for lunch. Fallon, 34 got it right. Good. Fallon's, it is indeed the Fallon's test. Next slide. Lal maintaining the lead. 1,000 ahead. Mansoor Kochi is climbing. Fallon, next slide. Edson for cervical rib. Next slide. the Finkelstein for decurrence, and Allen's for the superficial and deep radial arches. Next slide. 9th question. Which is a synucleopathy? We have tauopathies and synucleopathy. CBS, MSA, PSP, or Alzheimer. One among this is a synucleopathy. We have so many degenerative disorders. No negative marks. All can attempt. It's MSA, not PSP. Alzheimer's we know is a tauopathy. Next slide. What are the synucleopathy? Next slide, please. Lal, MLN, Sona Satyan in the first 3. Nammal 9 questions. Next is the 10th question. Lal, I think you are on road for the next prize also. So we have synucleopathies, MSA, Parkinson, and DLB, and tauopathies, AD, Alzheimer, PSP, and corticobasal syndromes. Next slide. If you are not complicated, there are more confusions from TDPs, amyloidopathies also. Next slide. The 10th question. Name this knee hammer. We all are using this knee hammer. Is it a Taylor, Babinski, Kuensker, or Tromner? Name this knee hammer. And name it quick. It's a Kuensker knee hammer. Next slide. Most have got it right. MLN. Who is MLN? Mohan Leslie Noon. Be there. Yeah. Mohan. Right place, right time. Like Lineker. That is again 1000. So Mohan Leslie Noon has overtaken right place, right time. And we are halfway through. Next slide. These are the types of knee hammer, the Taylor or Tomahawk. This is the Kuensker, most popular, Babinski, and Tromner. Next slide. We are halfway through. Here is our secretary with his Benz or auto. I love Kozhikode. We were here for 10 years. Next slide. 11th question. Not one of the small 5 muscles of the hand, which is supplied by the median nerve. One of it is not supplied by the median nerve. (39, 40, 41). Adductor. Adductor pollicis is the one supplied by the ulnar nerve. That's it. Next slide. Sona Satyan. MLN has got it right, but he took few more seconds. These are the loaf muscles. Lateral to lumbricals, opponents, abductor, flexor. These are the thenar eminence muscles supplied by the median nerve. Adductor is the ulnar. Next. Next. Percussion was described by. His father owned a wine vineyard or something, and he was percussing the barrels to find out whether how much it was full. Is it Littmann, Lennox, Ornbrugger, or Morgagni? It is Ornbrugger. Lennox discovered the Steth. Littmann is the brand. Sona Satyan rising again. Who is Phoenix rising? Who is Phoenix? Phoenix rising 6 in a row. Binami aano. Vidille. Ara Phoenix ara? Phoenix. Paul is rising. Yes. Paul is rising. Last adicha madi. Adana biggest prize money. We have time. Next question. percussion. His father had this. Yeah, that's it. Next question. MCA, large malignant MCA, 80% mortality reduced to 30 by an early decompression. We have several studies. What's the NNT? 80 is reduced to 30. We have a 50% reduction. What is the NNT? Number needed to treat. You have Decimal, Destiny, Hamlet, Zenith, all those studies. What is the NNT? Lower the NNT, better the efficacy of the surgery or procedure or the drug. The NNT is 2. Only 14 got it right. Yes, next. Rafa. Who is Rafa? Rafa. Yes, good. NNT is inverse of the absolute risk reduction. 80 minus 30 is 50% risk reduction. 100 by 50 would be 2. 2 is the NNT. Next slide. You put something in the external auditory canal. Oh my God. ഞാനൊരു മോഹൻലാലിനെയാണ് വെച്ചത്. Is it Arnold 5th, 8th or 9th nerve? It's the indeed 10th nerve, the Arnold or Alderman's nerve. Mohanlal ingane cheyna GIF was not probably working. It's the Arnold nerve and all have got it right. Next slide. 15 aya. Eh? Next is the 15. 15 kanya. Anna, Sona Satyan gets a prize now. Sona Satyan. Rajiv, the HOD neurosurgery will be giving a prize to Sona Satyan. We are at 3 quarters. We have 5 more questions for the last bumper prize. Sona has, we had 3 different people. The leaderboard is changing. Good. 16th question. Kugati is back in the game. Who is Kugati? 3 in a row. Good. Next slide. Number 16. Next. Next. Father of modern neurology, Charcot. He was working at Petit Salpêtrière. Where is this situated now? The Mecca of teaching neurology, which they all have good football teams. England, Portugal, France or Germany. The 19th century Charcot students were Babinski, Freud and father of neurology. France, it's in Paris. Most have got it right. Next slide. It's in Paris. Next slide. ASP, who is ASP? ASP, yes. Next slide. He is from Portugal. He got a Nobel Prize. He has 2 discoveries. One is angiography. One is a prefrontal lobotomy. One flew over the cuckoo's nest. Mohanlal cinema ഏതായിരുന്നു? താളവട്ടം. അതിലൊക്കെ ഉണ്ട് സർജറി. Name the neurologist who has 2 major discoveries from Portugal. There's a university in Lisbon or in his name. No neurosurgeon should make a mistake in this. Yes, Igas Moniz it is indeed. Igas Moniz is the right answer from Lisbon, Portugal. Next slide. Now coming to a patient, you have to name the patient. Our understanding of frontal lobe is due to, we are thankful to him. Is it Phineas Gage, Augustus Ditter, Cunningham, or the Alzheimer? You have to name this patient. Yes, indeed it's Phineas Gage. Gage was no longer Gage. That's the quote. His behavior was changed after the surgery. Sona Satyan in a thick lead. You have 2 more questions. Coming to the last 2 questions. Next slide. 3 more. Root value of the medial hamstring reflex. You have the ankle jerk, knee jerk and one more. Medial hamstring reflex. What's the root value? L4, L5, S1, S2. This is found to be very useful, especially in disc disease. Clinically, practically also useful. It is L5 because S1, S2 is angle jerk, L2, 3, 4 is the knee jerk. L5 was orphan. Now we have a reflex for that. That's the medial hamstring reflex. It's L5. Next slide, please. Next slide. Sona Satyan and MLN and Phoenix close on her heels. Next slide. How do you check? In a prone position, put the medial hamstring, tap over the finger just like you do on the biceps jerk. Next slide. Hip abductor. Can you recognize me? Not my car. What's the hip abductor? Gluteus maximus, medius, gracilis or sartorius? Yes, that's the medius. That's the hip abductor. You have the Trendelenburg or the waddling gait when there's a weakness. That's a next question. Is that last question? Coming to the last question, Sona Satyan in a thick lead, MLN and Phoenix close behind. Reggie Thomas? Reggie Thomas, yes. This appearance is seen mostly in, look carefully here. There are 2 white dots. This spinal cord appearance is seen in B12 deficiency, copper deficiency, ASA occlusion, MS. Last question, that is ASA occlusion. B12 deficiency is similar, but it's like a rabbit ear. The same picture we see in copper deficiency also after bariatric surgery. The answer is the snake eye appearance in ASA occlusion. Next slide. The final results. Sona Satyan first, Phoenix Rising, Paul second, Mohan Leslie Noon third. Shall we call upon our secretary to give away the prizes? First, second, third. Third place we have MLN, Mohan Leslie Noon, third. Second, we have Phoenix Rising, that is Paul Jacob and Alpha. And in the first place, we have Sona Satyan. Good job. Then, yes. Next, who is EJP? Who is EJP? EJP. Too late to climb. Yes. Next slide. That's the snake eye. Next slide, please. That's the eye of the snake or the owl eye. The eye of the snake in ASA in ischemia. That's it. Thank you. Next slide.
Thank you, sir. I request our organizing secretary, Ashraf sir, to please hand over a memento and certificate. Thank you. We will now be proceeding with our valedictory function.
Let me thank the CNS team, Calicut Neuro Society, Dr. Ashraf, and team Icon, Mr. Binesh and team from Icon for making this a success, and the Kahoot app and all were sponsored by Icon Sciences.
We will be proceeding with a valedictory function. I invite our President, Kairali Neurosciences Society, Dr. Jacob Alapat. I also invite our Secretary, Kairali Neuroscience Society, Dr. Tinu Ravi Abraham, our Organizing Chairman, Dr. Rajiv, and our Organizing Secretary, Dr. Ashraf Vivi, onto the stage. I would like to request our President, Dr. Jacob Alapat, to please say a few words.
Usual routine talk. Thanks all of you from the bottom of the organizing committee and from the KNS Neurology Society, CNS, for coming and making this conference a success. I think as I said previously, until the last person reaches home, this conference is not over. So please take off as early as possible after your quick lunch and drive back safely and carefully. That's what all I have to say. And take enough rest tonight and get back to work from tomorrow. And God bless you all. And from whatever you learn from this, if you have to do some backup reading this is for the younger guys, if you have not followed something, if you feel this area of mine has a lacuna in my knowledge, this is an opportunity to realize that. So that is how conferences are. You should read before you come for the conference, and you should read after you reach. It was customary in our department, after you attend a conference, all in the department sit together and tell something, what happened during the conference and what new things you learned in the conference. These are all very important to keep the department going. This is all very important for the individual to grow. This is all very important for the collective thought process in the department. So everybody will learn. If you might have, this is very important, because what I'm telling you, I find many a time you do not sit in the sessions and hear with books and notebooks. If you do that only, you will learn. Hereafter at least, there is nothing small in that. I feel doing it now, but my point is, as I said, just taking one more minute. Somebody said, sir, you are getting fat, you are not exercising. Then I said, previously I used to do exercise because I wanted to operate acoustics. Now my point of exercise is only to keep my life going. So your priority and your things change as you age. For you, the priority is now for studies. I think, what's the next thing? Tinu has to say.
I invite our Secretary, Dr. Tinu, to please say a few words.
Secretary of the Kairali Neuroscience Society, I have to mention some names before we disperse. Of course, yesterday, as told in the inaugural function and LGB, this was a splendid, very nicely conducted conference. There is no doubt about it in the minds of all the people who came, because from talking with almost all the persons, I came to know that this was one of the most wonderful conferences we have attended in the past. That is one thing. Second is the organizing committee. Of course, this successful conference is the result of the hard work of some of the people of the organizing committee. Usually what we see is that 2 or 3 people may be the responsible persons who may be running around and doing all the things, but here we see that we have a very large organizing committee. So mentioning the names of everybody is not possible, but still I would like to extend the special thanks from the society to Dr. Rajiv sir, and Dr. Ashraf sir. And there are certain persons who have never come to this stage for receiving any recognition. And out of them, I would like to especially mention Dr. Shivkumar sir. We all know how hard he was working for arranging every entertainment aspect of this conference. That was wonderful, sir. Then, of course, our scientific sessions were conducted by Murali. He was always standing there with laptop. He has left because he was busy. Then also another person is this Baijo. He has always been in that chair. And Dr. Aishwarya, she is also a resident at MIMS. Then Dr. Mohan Leslie Noon. He is the financial power behind all this. And last but not the least, our own Vijayan Pittakandi sir. He is among us, yes. Then the persons who were arranging the workshops at Medical College Kottayam, Calcutta, was Dr. Binoy, Dr. Svi, and there were a lot of youngsters were behind that. Some of them even could not come to the conference because of the responsibility in the department. So I thank them all for giving us an academic feast. Then, of course, the other aspects of Thanksgiving will be dealt with by our organizing chairman and secretary. So we wish we have a better conference each year, because each year we are witnessing a better and better conference. As I told yesterday, the organizations, growing, measurement of the growth is being perceived from the way in which these conferences are organized, and also the participation. So with that, I will conclude my words.
See, organization of the conference, and I will interrupt you. It's not based on the DJ performance. That we should concentrate more. We should have DJs, we should have fun, but we should have more of interest in academics. And PGs should take part sincerely in these sessions, not in the award paper. They come just in the morning, finish their award paper, leave the place. They will not be learning in that. You should be attending each thing, each of these talks very fervently and reading back and front. That is the most important thing in it. Fun, this conference was intended for fun and family. There is no doubt on that. And we could do that. I am not telling you, but every place conference cannot be held like that, because this hotel belonged to this gentleman's father-in-law. That's why we could do that. And another thing is, Wayanad was a place we chose with a lot of skepticism. It is God's blessings that we have till now no much issue, and we are just going through the last phase of the conference. So if every conference next year and all cannot be conducted like this, we still have a lot of practical difficulty. We are just telling in the spirit of that, but more important is the academic aspect of it. Please. And in the organizing committee and all, it was all starfish hypothesis. No president, secretary, everybody was doing everything. There was no hang-ups. There was no formalities. The more lesser and we do on such things, the more we will progress in life.
I would like to request our secretary to hand over the mementos to our organizing secretary of the conference, Dr. Ashraf VV. Also to our organizing chairman of the conference, Dr. Rajiv MP. And to our treasurer, Dr. Mohan. Thank you. We will now be announcing the prizes for our free paper and poster presentations. I request our President, Dr. Jacob Alapa, to do the honors. We will be starting with our neurosurgery paper presentation. The third prize for our neurosurgery paper goes to Dr. Ebi K. Sebastian. He's from Calicut Medical College. A second prize is to Dr. Mohammad Mansoor T. from Medical Trust Hospital, Ernakulam. And our first prize is to Dr. Shinaz Hussain from Government Medical College, Kozhikode. Next, we have the prizes for a neurosurgery poster presentation. Third prize is to Dr. Pradeep Kumar from Government Medical College, Trivandrum. Second prize is to Dr. Rizwan Said from Medical Trust Hospital, Ernakulam. First prize is to Mohammad Mansoor T, Medical Trust Hospital, Ernakulam. Neurology paper presentation prizes. Third prize is a tie between Dr. Sneha VP from Government Medical College, Kottayam, and Dr. Rashma from MES Medical College, Perindalmanna. Second prize is to Dr. Ram Kumar, Government Medical College, Kozhikode. First prize is to Dr. Paul Johnny, Aster MIMS, Kozhikode. We will now announce our poster presentation prizes. Third prize is to Dr. S. Arun Pranav, MES Medical College. Second prize is to Dr. Ashik Hamza from Maitra Hospital, Kozhikode. First prize is to Dr. Sona, Trivandrum Medical College.
For the poster, we have a special prize for a good presentation for Dr. Aishwarya.
She had finished her MBBS from Wayanad MIMS, and she told she wants to go for USMLE exam, so she wants the preparation for that. So she joined the neurology department, and she was working voluntarily. She had cleared all her steps for USMLE. And actually I contacted Anil P. Anil P's daughter also has gone the same, that 5-year direct neurology course. So she is planning to go for that. And she is a good learner, very correctly positioned aspirant postgraduate. And that's why she helped us through a lot, the neurosurgery team, for all her Master of Ceremonies job. So thank you especially, guys.
Thank you. We have a final talk. We have a vote of thanks by Dr. Vijayan, President of a Calicut Neurological Society.
Good afternoon, everybody. It is customary to give the vote of thanks by the Calicut Neurological Society. My half of the job was already done by Tinu Abraham. Just for completion's sake, I have to say a few names on behalf of Kairali Neuroscience and the Calicut Neurological Society, and on my personal behalf. I thank all the organizers, KNS President, KNS Secretary, and the organizing chairman and secretary and the treasurer. Everybody knows or everybody names. My sincere gratitude to our senior faculty and the patron and who has given the inaugural address, Dr. Srikumar sir. I sincere personal thanks to sir. Next, I extend my sincere thanks to Professor Ramanal Mohan sir, who has come a long way with his half the health issues to receive the this year's prize as a full lifetime achievement award. I sincere thanks to the organizing team. Now I am not taking any name individually. The full members are there on and off the scene. Few names like Murali Krishnan, Binoy, Baijo, Paul Alapad, and other things. I think to cut short, I give my sincere thanks to everybody who has participated and made this event very successful. Okay.
So with that, we'll disperse. We are also happy to announce that we have distributed total prizes worth rupees 1.5 lakhs for this PG's poster and paper presentations. So thank you all. Have a very happy journey back home. Next we'll have, we'll conclude with the national anthem.